I believe we start on time and then.
Okay. I'm going to ask everyone to please take their seats. It seems that the webcam is now currently functioning, which is, I'm not sure it's a good thing, but anyway. I'm going to ask that we all use our microphones to make it easier for people that want to hear us. And we're going to get started. So good morning, everyone. I'm going to please ask you to turn off your cell phones, or at least turn them to silent and make sure they're off the table. Please make sure your BlackBerries are also off the table so we can avoid any of the feedback noise that we usually get to hear. I'd like to ask anybody that's going to be a speaker on any issue to make sure they filled out a speaker slip and give them to Ms. Thompson. Ms. Thompson, your hand is raised. Thank you very much. And I want to remind the speakers to please stay on topic and to keep their comments to 3 minutes, and to remember that we will not be engaging in any kind of back and forth conversation. The opportunity to speak is your opportunity to speak. We will listen to what you've said, but don't expect a conversation, please. So I'm going to ask, we're going to call this meeting to order, and I'm going to ask for the roll to be called. Ms. Thompson, would you come forward, please?
Dr. Karyan, Ms. Chang, Dr. Chin,
Here.
Dr. DeRusso,
Here.
Dr. Israelian,
Here.
Dr. Gitnick,
Here.
Dr. Levine,
Here.
Dr. Lowe,
Here.
Dr. Moran,
Here.
Dr. Solomonson,
Here.
Ms. Shipsky,
Here.
Mr. Zrunyan, and Ms. Yaroslavsky.
Present.
We have a quorum.
Thank you very much. I would like to introduce our newest board member and ask him to come forward to be sworn in. Dr. Eric Israelian is a physician from UCLA and was appointed by the governor on June 9th, 2010. So, Eric, if you come, I guess you should stand up. We'll do this officially. Okay? It's the office for the member of the board of the Medical Board of California. I, Eric Israelian,
I, Dr. Israelian, Eric Israelian,
do solemnly swear
do solemnly swear
that I will support and defend the Constitution
that I will support and defend the Constitution
of the United States and the Constitution of the State of California
of the United States and the Constitution of the State of California
against all enemies, foreign and domestic.
against all enemies, foreign and domestic,
That I will bear true faith and allegiance
that I will bear true faith and allegiance
to the Constitution of the United States
to the Constitution of the United States
and the Constitution of the State of California.
and the Constitution of the State of California,
That I take this obligation freely,
that I take this obligation freely
without any mental reservation or purpose of evasion,
without any mental reservation or purpose of evasion,
and I will well and faithfully discharge the duties upon which I am about to enter.
and I will well and faithfully discharge the duties of which I am about to enter.
You're so sworn. Thank you.
Sounded to me like you're sending into a rock.
No military service in this building, please. Pursuant to Government Code Section 11126, subsection E, subsection 1, the board will meet in closed session now to confer with its legal counsel regarding the following litigation: Shiley versus the Medical Board of California et al., Superior Court of California, County of Sacramento, case number 05A S03244. So I'm going to ask, please, that everyone except the board, our Deputy Attorney Generals, and Kurt Hepler, our lawyer in this matter, our staff counsel, please leave the room, and we'll be notified when to come back. I'd like to urge everyone to come forward and sit down, please, to get back on this meeting schedule.
This termination thing.
We're going to continue with the agenda, item number 4, the presentation of the Physician Humanitarian Award. The Physician Recognition Committee was created several years ago by the Medical Board to recognize the demonstration of excellence by an individual physician or group of physicians who strive to improve access and to fill gaps in the healthcare delivery system for underserved populations. Nominees must demonstrate a creative model of dedication to the development and delivery of inspirational, successful, and replicable models of healthcare delivery, or demonstrate service in an area of medicine that advances the public health care and public's health care status through clearly outstanding service, education, or innovation. Dr. Richard Pan is board certified in pediatrics and has a master's degree in public health. He practices general pediatrics at UC Davis Children's Hospital. He is director of the Communities and Physicians Together program and is the associate director of the Primary Care Outcomes Research Fellowship, part of UC Davis's Center for Healthcare Policy and Research. Dr. Pan is a leading child health advocate, medical educator, healthcare reform activist, focused on bringing community and healthcare organizations together. He began his work as healthcare advocate over 10 years ago, when as a resident pediatrician in Massachusetts, he worked to support legislation to expand children's healthcare coverage. After moving to Sacramento in 1998, he became a well-known voice for children's health, serving on numerous boards and commissions, including the first 5 Sacramento Commission, the Healthy Kids, Healthy Future Program, the Sacramento Health Improvement Project, the United Way of California Capital Region, and the Impact Council. And I assume you practice medicine at the same time. Dr. Pan has served as a medical consultant to the Sacramento City Unified School District since 2003, providing in-service training to school nurses and advocates for adequate school nursing staff in public schools. He developed a protocol for the district to facilitate the diagnosis and treatment of students with attention deficit hyperactivity disorder, which involved training school nurses to coordinate care between a student's medical and emotional teams, educational teams. He also established a partnership between UC Davis Pediatric Residency Program and school nurses at 6 elementary schools in the district to teach students about nutrition. For these efforts, he received the Lydia Smiley Award from the California School Nurses Organization. Dr. Pan founded and serves as the director of the nationally recognized Communities and Physicians Together program at UC Davis School of Medicine. The program teaches young pediatricians to gain a broader perspective about patients by understanding their home environment and community, and places physicians in disadvantaged communities to promote population-based health. The program received the 2005 Community Campus Partnerships in Health Award, and Dr. Pan received the 2008 Campus Compact Thomas Ehrlich Faculty Award for Service Learning. The Ehrlich Award is bestowed by Campus Compact, an organization of more than 1,000 college and university presidents committed to fulfilling the public purpose of higher education by promoting service learning. For your many years of work, and from your so many angles on behalf of a most vulnerable population, and especially for your innovation in the models of the delivery of care of children, the Medical Board of California thanks and congratulates and commends you. And please come forward to accept your award. And if you'd like to address the board, we'd be pleased to hear from you. Dr. Pan? Right from the chair. Thank you.
Well, I want to thank the Medical Board for this tremendous honor that you have bestowed upon me. It's always extremely gratifying to have received recognition from the state of California and from such an esteemed group like yourself. I just want to make a few remarks because I know you have a busy agenda today. I just first of all, just want to say that I think in terms of why I did the work that I did and why I think physicians do the work that they do is, first of all, is that we want to try to promote health overall. So while this board addresses issues around quality of health care and delivery by the quality of physicians, and we often focus a lot on health care when we talk about reform or whatever, that it's also important to realize that we are trying to work on health, which is why I started Communities and Physicians Together, is to get physicians out of the sort of traditional healthcare settings, the clinic, the hospital, and get them out into the community so they can partner with communities to improve health overall. And I think certainly the research on determinants of health demonstrate the importance of doing that. And so how do we link healthcare activities with health and community is very important. Second of all, I think that it's really important to also remember that how everything is interlinked. That and certainly I think in this time when we're talking about constrained budgets at the state or at the local level, or how do we, in this depressed economy, to recognize that too often people look at things as being siloized, but what happens is that if you're cutting back mental health, that has an impact on public safety, and if you cut back on our environment, that has an impact on health. So we need to understand how everything is interconnected, and again, that's one of the reasons that I felt so important, not only to get our physicians out in the communities, but also how important it is to be sure that every child has access to health care, because that actually not only is beneficial for themselves, but also for all the other people that are together. And finally, I think that we have to also recognize, and not only here in the state of California, but certainly throughout, the importance of that our biggest resources are so-called our human resources, the people who live in the state, and how important it is, again, to ensure that we invest in everyone in the state. And I think that we don't really, and as rich as we are, I don't think we can afford to waste any person. And that's why, again, it was to me very important that we reached out into the communities, reached out to be sure we got every child health insurance coverage. Also, how do we try to, as the Medical Board of California, how do we be sure that we have a physician shortage? How do we be sure we utilize every physician as well to be sure that people receive quality health care, and also to ensure that everyone is able to get safe health care as well. And I think certainly that's one of your roles, is to be sure that every physician and other providers are qualified and are performing safely. But I also hope that you, and I know this is an issue you've wrestled with before, but I also hope that I know that we've had issues. For example, there are certainly physicians who've had their own challenges, and that we need to ensure that those physicians are able to come forward with those challenges and be sure they get addressed, so that their patients can continue to get safe health care, and also to ensure that people continue to access. So I know that you've wrestled with issues like, for example, the diversion program, but I think as someone who's been involved in residency education, and knowing that, I certainly like to hope that every one of my trainees and all my colleagues never have any problems, that when they do have issues, that we need to create a pathway for them to be able to practice safely, and that we can't just write them off and say that, well, if you have a problem, we can't, there's no path for you to be able to practice safely. And I hope that that's something that you'll revisit sometime in the future. And I know it's a very challenging problem. Certainly as an educator at my end, do I progress a resident forward who has a challenge at your end, to ensure the safety of the citizens of California, which certainly is your most important role. But again, I want to thank you so very much for this honor you've bestowed upon me. And again, I think that there are many other physicians doing many other wonderful things, and I'm certainly I want to express my gratitude to you for taking the time to recognize this kind of work, and I really appreciate it. So thank you so very much.
Thank you very much. Thank you. I don't have any speaker slips, so I'm going. Oh, I do have a speaker slip. Thank you. So move on to agenda item number 5, please. Frank Cuney, would you come forward, please, and address us on public comments not on the agenda, please? Nice to see you, Frank.
My name is Frank Cuney. I'm the Executive Director of California Citizens for Health Freedom, a nonprofit organization that seeks to defend the rights of physicians to practice safe, effective, alternative type of treatments, non-conventional medicine. And first, I'd like to thank Barbara for her leadership she gave to the board for the past year. And I want to compliment the board over its history of dealing with the right of physicians to practice non-conventional medicine. The bill that we had requested a number of years ago, we tried about 4 or 5 times to have it up, and it got defeated in committee, and then finally Senator Vasconcellos passed a bill requiring this board to set up a committee on alternative medicine and look at ways that physicians who practice non-conventional medicine are disciplined and study the issues. And they were looking at 2 issues. They were looking generally at the non-conventional medicine issue. Of course, what the act was trying to change is that stated that physicians are licensed to practice conventional medicine. So if they did anything non-conventional, And we talked primarily nutritional approaches and things like that with people that was against the law. So the board did set up a committee to examine the issues, and they eventually sponsored the bill that was passed in California and made some remarkable changes in what goes on with physicians' right to practice non-conventional medicine and not have to use as much drugs and use non-conventional approaches. Of course, they spelled out the requirements that they have to be safe and effective, and the patient must know how to do that. And the board committee was going to look at the issue of non-conventional treatments of cancer, but at that time the existing governor took the money away from the board and the committee could not meet anymore onto it, so that issue did not get before the committee to really discuss in the fullness of what went on, and we're hoping that to introduce a bill this next year to do that. The board also took issue on the Lyme disease issue when the Lyme Disease Association on practicing a long-term use of treatment of Lyme disease, that the national organization was saying, no, that's not the way, there's only one treatment approach, and the use of the long-term antibiotics is not an effective approach. And I suggest the Lyme disease organization meet with the medical board, which they did. The board examined it, and the board ruled that in California there are two approaches that were legal to treatment of Lyme disease, and one against the national situation. Now national is looking to follow California's leadership on approaching the other. The other issue that I think the board did a good job with was the issue of midwives. That when the law was passed that midwives had to be licensed and they had to be under physician supervision, and then the board discovered that no physician in California would sign a physician supervision agreement because of the insurance and the possibility of losing their hospital privileges. It meant no midwife in California could practice. And the board reached a decision that on that they would not discipline midwives. They disciplined midwives if they did wrong and had ineffective practice and were doing things wrong. But on the single issue of supervision of physicians, even though the law stated that, the board ruled that they would not impose upon that because that would remove their ability to practice and stop the ability of citizens for using that particular type of service. So I'd hope as we introduce a bill this next year, the board would look at non-conventional treatment, integrative treatment of cancer. Our bill will have three features. One, licensed physicians and naturopathic doctors would be able to offer the treatment. Integrative treatment of cancer would become legal, and parents would have the right to select the type of treatment they have for their children. And that's been a big problem in California. I hope you look at that and examine it and take a leadership role that you've done in the past. Thank you very much for your time.
Thank you very much for your time, sir. I'm going to ask for approval of the minutes from the April 29th, 30th, 2010 meeting.
So moved.
Second. Any public comment on the minutes? Any additions or corrections? Seeing or hearing none, all those in favor?
Aye.
Any opposed? Seeing none, the minutes have been adopted. So we're going to move on the agenda, and I'm going to start the regulatory hearing. Good morning. My name is Barbara Yaroslavsky, President of the Medical Board. I will be presiding over this hearing. This is the time and place set by the Medical Board to conduct a public hearing on the proposed regulation to amend Section 1306 of Title 16 of the California Code of Regulations as described in the notice published in the California Regulatory Notice Register and sent by mail to those on the Board's mailing list. The Board is seeking to amend the regulation related to the abandonment of applications to keep it current and useful. Specifically, this rulemaking will replace obsolete, ambiguous terminology with concise language that establish what actions are necessary on the part of an applicant to prevent his or her application from being deemed abandoned by the Board. This proposal would also require that applicants notify the Board of a change of address within 30 days. For the record, today's date is July 30th, 2010, and this hearing is beginning at approximately 9:10 a.m. We ask that persons in attendance print their names on the roster at the room's entrance. If you wish to testify, please indicate that on the roster sheet. The purpose of this hearing is to receive oral testimony concerning the regulatory proposals described in the notice. Regulations must comply with 6 legal review standards, which are: 1. Necessity. Is there demonstrated evidence that there is a need for this regulation? Authority. Does the board have the legislative authority to adopt the regulation? Consistency. Does the regulation conflict with other regulations or statutes? Clarity. Can the regulation be easily understood by those affected? Non-duplication. Does the regulation duplicate other regulations or statutes? Reference. Which statute does this regulation implement, interpret, or make specific? Testimony should address only these 6 standards. Before we begin, I would like to briefly describe the procedures that will be followed. The entire hearing will be tape recorded. Those persons testifying will not be sworn in or be cross-examined. All recommendations and objections will be considered by the board members. Responses to all objections or recommendations will be included in the final statement of reasons. The board will maintain a rulemaking file on this proposed regulatory action. Written comments for the regulation being heard today must have been received by 5 p.m. on July 26, 2010. The recording of this hearing, written testimony, and all written comments received by the deadlines as noticed will become part of this rulemaking file. A completed copy of the rulemaking file will be available for review at the Medical Board's office in Sacramento. All testimony must be submitted by the deadline mentioned above. However, no written comments were received by the notice deadline. To ensure fairness and that everything is completely entered into the record and to enable everyone to hear those who are giving testimony, we ask that those testifying follow these simple procedures. Please speak loudly and clearly. Identify yourself and who you represent. Please state your position, support or oppose at the beginning of your testimony. Oral testimony will be limited to 3 minutes per person. Please do not repeat testimony already given. Any written comments you have with you today should be summarized orally but should not be read. I would like to ask Ms. Boyd to please come forward so we can start the public hearing regarding the abandonment of application files. Ms. Boyd and Ms. Scurry, please proceed with the information regarding this regulation.
This regulation was the product of staff's review. There were lots of applications where they remained on file for 10 years, 15 years, and it was because the language was so vague. All someone had to do to retain their application on file was to say, yes, I'm still interested in licensure, even though they were taking no further steps toward licensure. This regulation is an attempt to set out criteria by which a person will be considered to have abandoned their application, and it will be closed, and they would have to submit a new application so that applications do not remain open and on file for 10 years, sometimes longer, sometimes less. So we tried to cover all of the different situations that might arise and apply reasonable time frames. For instance, if an applicant receives a deficiency letter and they don't submit the required information within 365 days from the date of the request, then that application would be deemed abandoned. There's a list of about 6 of those in here. The other is a requirement. Applicants sometimes change their address and the board needs to communicate with them, and they haven't filed a change of address. It's very difficult to find them again sometimes, and so it would be useful to have them report changes of address to the board while their application is in progress. As licensees, there is such a requirement, but there hasn't been one for applicants. Did I leave anything out? No, you didn't. Are there any questions before you have any public comment?
No.
Were there some technical amendments?
There is one technical amendment. Let's see. There's a set change to, we didn't do our alphabet very well. So after C should come D and not E. Are there any questions?
No questions from the members. Are there any public comments? I have no slips on anyone wishing to speak, so I'm going to close the hearing. Thank you very much. So we're going to move.
So
Ms. Ford?
Sorry, I left too soon. What would be, after you discuss this, if you have any discussion, what would be appropriate would be a motion to adopt the regulation with the one technical change from relettering the last paragraph from E to D.
So I need to entertain a motion to adopt with the correction in the alphabet.
So moved.
Any public comment on this? Seeing none, hearing none other, vote to adopt the language as written and delegates the executive officer to complete this room as amended.
As amended.
Okay?
That's fine. You don't need any further.
Okay, thank you. All those in favor? Any opposed? So done. So I'm going to move to my report on interested parties. I had a meeting with the City of Hope, their medical director, and the president and chief executive officer and their government relations team. There was a discussion about their moving to a medical foundation model versus what they currently have. They feel that this change will give them more flexibility to move their institution forward. I also received a tour of their facilities as well as a spirited discussion over lunch. I was most impressed by the collaborative participation of this facility as with other very well recognized institutions. For those who aren't aware of the status of how a hospital operates, as I was not, the medical foundation model is one used by many of our premier institutions, including in Los Angeles Cedars-Sinai. I believe that the SHARP system in San Diego is also a medical foundation model, in contrast with the Kaiser Southern California Permanente Medical Group, which is a medical group model. The Cedars Medical Foundation has been in existence for 20-plus years, and I believe that medical foundations have been in place for that many years as well throughout the state. The medical foundation model offers alternative practice model for physicians who want to practice in a group setting but don't have the capital or don't want to reduce their income to invest in the infrastructure to operate a group practice. It is a legitimate model allowed by the California Business and Professions Code. The physician is not forced to join a foundation in order to practice. So that I also want to continue that during the last quarter, I also met with Senator Gil Cedillo on the board's opposition to SB 1410, which would remove the limitations that an applicant for licensure must pass Step 3 of the USMLE within 4 attempts. We had a good discussion, and no conclusions were really reached. This is a matter for discussion during the legislative agenda 13, item 13B in your agenda. On July 13th, I participated in an hour-long conference call with the director of the Department of Consumer Affairs, Brian Seeger, his deputies, and other Healing Arts Board presidents and executive directors. We had an update on the budget, federal health care reform, licensing reform regulations, the July 27th training day that happened this week, and the uniform standards for diversion programs. This included the availability of funding within the health care reform and not being able to spend monies until a budget is passed, which I'm sure we're all aware of what's going on with that. These calls will be held monthly. The next one is scheduled for August 10th. And if I can't participate as the chair, vice president or another person from my board will participate. I also want to, at this time, mention that the Education Committee's report is not part of your agenda, so I want to let you all know that we did have, yesterday we did have an Education Committee. We had 4 physician experts address our committee on the subject of educating the physicians and the public about hepatitis. We met on this topic after the board at its last meeting asked us to do so after it considered a bill on this topic, AB 2600 by Assemblymember Ma. All 4 physicians agreed we need more education for all. Several have specific ideas, and we will be following up to determine appropriate actions for our board at our next meeting, and we will come up with some ideas and suggestions for them. I would like to take a moment to acknowledge a medical board staff member, Debbie Nelson. And I'd like Debbie, who hopefully is in the room. Thank you. And it's her birthday. Happy birthday, Debbie. but I wasn't acknowledging you for your birthday, to be honest with you. But she's an analyst in our communications office, and she's the person responsible for the production of our newly revised and published Guides to Laws Affecting Physician Practice. All board members have been given a copy, and some copies have been made available on the back table as well. This is a very important booklet. Newly licensed physicians are mailed copies upon licensure, and it's their practical guide on how to follow the law. It took Ms. Nelson 7 years to update this. Not because she spent 7 years doing it, because she had very little time to put together to do it, but she didn't give up, and I want to thank her for that. This is to research new laws, update existing ones, verify, edit, work on graphics, and to get information from other state agencies, all while doing her other full-time work for the board. Ms. Nelson, please thank you. Please accept our thanks on behalf of the entire board for your energy and work. Thank you. Today is the last meeting for our most tenured board member, Dr. Gary Yitnick. Gary has served on the medical board since April of 2000. He was originally appointed to the board's former division of licensing, where he has worked to improve efficiency within the board's executive staff. He served as president of the division before serving as president of the full board from 2002 to 2003. In his 10-plus years of service to patients of the state of California, as a member of this board, Gary has been a tireless voice in upholding our most fundamental responsibility, the promotion of patient protection. He has been our most vocal member, participating actively on numerous committees and willing to add his thoughtful remarks and even sermons to our meetings. I didn't write this.
I didn't expect this.
Well, I didn't want you to think that I thought you were giving us sermons. A decade is a long time for someone with a schedule as demanding as Gary's, and yet he made the time to honor his commitment to the citizens of the state, to the administration, and to his fellow board members. He was very instrumental in increasing the amount of information the board now provides the public about our licensees, a controversial issue that often left him at odds with many of his peers. Perhaps Gary's most outstanding contribution to the medical board and the public is his creation and support of the Physicians Core Loan Repayment Program, which provides an economic incentive for newly licensed physicians to practice in underserved areas. We can only imagine the number of Californians who have received medical care because of Gary's ongoing promotion in several venues to the issue of access to care across the state. Gary, on behalf of the many board members and staff with whom you have worked, and a public who may never have heard your name, but who are better served for your work on this board, I present you with a plaque as a token of our gratitude and administration. We will miss you, and we will wish you well. And, oops, now there's a bow. Thank you.
Did I get to say something?
And we would love to hear you.
Let me open this up first.
You could open it, and then you could. And here's the bow.
Point there, you know. Oh, it's beautiful, and I love glass.
He's serious about that. He has a beautiful collection of Chihuly pieces in his home. So I hope that you'll put this somewhere where you will look at it and remember and think of us fondly.
Well, let me take 5 minutes or so, maybe 2 minutes.
You can take all the time you want to.
I'm honestly surprised. I did not expect this, nor did I expect this at this time in this meeting. I'm so surprised. You know, it's like Bill Gates would feel if he bounced a check. But I would like to say a few words. First, I need to thank the staff. We are blessed with, and have been blessed, with a remarkable staff that works very hard, is underpaid, overworked, as I think I said yesterday. But were it not for the staff, none of none of what we do and what we take credit for, good or bad, would occur. I'm especially grateful to Linda, who I have great respect for, and her knowledge has been of exceptional help over the years. And to Kevin, who works so hard in doing such extraordinary things unexpectedly but perfectly. And I can't tell you how fortunate I think this board is to have Anita. Anita's legal skills are remarkable. She's brilliant. She always figures a way how to get things done, and she keeps us honest. And you have to listen to Anita. I also want to thank Julie. We don't always agree with Julie. I usually do. But now we don't always agree with Julie. But Julie is a dedicated professional. Her ideas are superb. And I got to tell you, even if you don't agree, you've got to listen to Julie, because in my experience, her guidance has been always on right the way it should be. She is knowledgeable and probably knows more about this board than any sitting member of the board. Well, there are certain principles that I was thinking about with regard to being a board member. We as a board have an onerous responsibility. We're charged with public protection, and we're charged with also being fair and just. And this is a heavy responsibility. To do it right takes a lot of reading and a lot of time. But there are also problems that come up in being a board member, and there are certain principles that I want to leave you with, probably unnecessarily, because I think most of you already follow these principles. But I think principle one is never fear doing the right thing. As a board, we sit on a very thin line. On the one hand, we are politically appointed. We are a political entity. The composition of the board changes as administrations change. On the other hand, we are charged with doing an ethical, proper, honest job. Sometimes the political side of what we do and the ethical side of what we must do are conflictual. In my view, we always should lean towards the ethical and proper. And sometimes we have to pay for that. But I do want to remind you, and some of you who have been on the board for many years know this, that during this past decade, we have been the victims of what I can recall of two evil empires within the political system. And it was because of the courage of board members, of the leadership of this board, that those evil empires were overturned. And those were courageous and difficult times. Another principle I think I want to convey is, as board members, we need to be humble. We are appointed. We are appointed by political people, either the governor or the legislature. We do not get these jobs on a merit-based process. That means we may not be the best people for what we're doing, but we have the job and we've got to learn to do it in the best way possible. And from my point of view, that should engender a certain level of humility. Now, it takes both rain and sunshine to make a rainbow. And there's been a lot of rain. There's been the problems related to diversion. where I must say I believe the board members were certainly not aware of the problems within diversion. Even when questions were asked in that time frame, we were not kept abreast of what was happening. There have been serious problems in licensing. I'm so proud of how licensing has been turned around just recently. Enforcement problems led to the subject of Julie's monitor report. Again, we were, as an organization, we were not aware of many of the problems going on in enforcement. And from time to time, we've had terrible press relations. At other times, we've had good press relations. But these are issues that need to be remembered and confronted. I'm proud that over this decade, I personally believe that this board, and I'll bet you Frank will agree with me, that this board has evolved from an organization that was highly protective of physicians to an organization that is exceptionally consumer-oriented while still maintaining fairness and justice with regard to our interactions with physicians. It was this board that finally recognized the place for midwifery and for alternative medicine while still protecting the public. These were contentious areas, but we came out of it, I think, on the right side. I'm most proud of the Stephen Thompson loan repayment program. The history there is a history of political intrigue, which I won't go into, because it did require a dramatic, behind-the-scenes effort to do something good. And I must tell you that without Linda and without Kevin, that effort would not be present, and there'd be a lot of poor people in California who are now getting excellent health care who wouldn't be getting health care. The Stephen Thompson program has placed hundreds of young doctors out into areas where they provide service without charge. We were also responsible for developing the volunteer license, which removed the blocks for retired doctors to give back to their communities and to provide health care to indigent patients. And finally, we, with political intrigue, with a lot of work behind the scenes, were able to evolve a system where the Thompson loan repayment program would have a continuing source of funds indefinitely without the use of taxpayer dollars. We were responsible for developing a regulation that requires that every school that we certify is reviewed every 7 years. Before 10 years ago, if you got certified by this board as an offshore school, you were certified for life. No one went to look. No one went to see if you're doing good or bad. We changed that. And finally, we decided that we should recognize excellence in healthcare delivery, and we developed the Physician Service Award, something which I believe is proper and an important thing that we have done. So I want to make some suggestions now that I'm leaving the board. One, and I'm just going to list these because I've thought about these, I think, carefully. One, it's important to work more closely with the California Medical Association. We've had times of total disagreement, of combativeness, and we've had times in which we've worked closely together as partners. We're now in the latter. We've been working more as partners with CMA, and we should. We still must always remember that our job is not to protect the doctor, it's to protect the public and to be fair to the doctor. But the Stephen Thompson program, for example, would not be present without the support, co-sponsorship, creativity of the California Medical Association. I believe, and I know many will disagree with me, that we should help develop a merit-based appointment system to this board. Now, I'm willing to grandfather all of you out, but I believe that future appointments to the board should be based on merit. And I believe it's proper for a board like this to decide what are the requirements for a board member, what background is needed. I believe that we should develop an internal monitoring system, and you've heard me lecture ad infinitum. But I believe everything this board does, not only enforcement, licensing, and everything else, should be regularly reviewed in a formal way by an outside, unprejudiced organization or person. Personally, I would clone Julie and have that person or organization periodically look at everything this board does. I believe that we should develop a proactive public relations effort. I'm proud of the work of our education committee, and education is important, but our public relations stink. We are not proactive in trying to reach out to the public. We should be. I believe that we should go back to establishing a media relations committee independent of the education committee. Media relations was established so that this board could speak with one voice to the public and to the press, so that the press would not come forward and interview 10 different board members and get 10 different opinions. We should agree on what as a board we will support, and our voice to the press should be one voice, and it should be through a media relations committee. I believe that we should be proactive in building or establishing a legislative relations committee. We are not, well, except for our executive director, who is well known and beloved within the legislature. We as a board are not known well within the legislature. We have a president now who is well known and has done a remarkable job in representing us properly before the legislature. But I'm worried about the future. And in the future, we need to have an active, proactive legislative relations committee that has the job of meeting with and discussing important things with members of the legislature. And finally, I believe that the position of president of this board has become so complex, not only time-consuming, but so complex and so difficult that it takes at least a year to learn how to be president. I believe we need to extend the term of the presidency of the board. I believe at least 2 years is appropriate. I know it would be unfair to deny all people the opportunity to be president at some point. But what I always try to come down on, and I know most of the board, when you have a tough decision to make, you always try to think of what's best for the public. That's what should be our goal. What's best for the public? And I think it's best to have a leader who finally knows how to do the job and hold on to that leader. And finally, I want to thank all of you. Thank you for putting up with me, for listening to my lectures and my sermons. And I sincerely hope that you'll always do the right thing. Thank you.
Thank you. So well stated, and words to live by for sure, and thank you for making them. Moving on the agenda to item number 10, the election of officers. At the July 29th meeting, the board voted to change the date it holds its election of officers from the last meeting of the calendar year to its July meeting. The board also voted that the newly elected officers officially enter into these positions at the conclusion of that board meeting. I would like to open up the nominations for president of the board and any additional nominations.
Madam Chair, I would like to nominate Barbara Yaroslavsky to be president of the board.
Second.
Thank you. Okay, anyone else? Are there any other nominations? I don't have to public comment, do I? So I assume I don't have to do public comment. Do I have to do public, should I do public comment? Certainly, I don't have any public comment slips, so therefore that's gone. So all those in favor of that?
Aye.
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 Opposed? Any abstentions? So be it. So in moving on to Vice President,
Well, to keep the consistency, I'm nominating Frank Zurini as Vice President.
Second.
okay, are there any other nominations? There's no public comment slips, so there's no comments. So all those in favor?
Aye.
Aye.
Thank you.
Well, in that same vein, I'd like to nominate Ms. Chang continue in her position.
Thank you. Thank you. All those in favor of that nomination?
Aye.
Any opposed? Any abstentions? So be it. Thank you very much. Ms. Whitney, I'm going to ask you now to, did anyone want to say anything? I really,
I actually would like
Oh,
to
okay, sorry.
express my thanks to Dr. Gitnick again. I know I went a little bit further on the schedule. I think I came in as a board member when licensing as a person who, this is almost 6 years ago. I know nothing about this whole thing. And Dr. Gitnick was in our division, and I think I learned everything from this great statesman about all the issues needs to be learned in an attitude. So I wanted to express my thanks and gratitude for all of us. Thank you.
thank you, Ms. Chang.
Thank you very much.
So moving right along, I'd like to ask Ms. Whitney for the Executive Director's report on item number 11, please.
If you would all please turn to tab 11A, that's page 139 of your packet. This page is an analysis of the fund condition of the medical board. I'd like to draw your attention to the projected current year 09-10. That is our projection at the end of the year to have a 5.8-month balance in reserves. Moving on to the budget year. Part of the reason it is so high is because there were reductions in staff salaries during the year, and those then are reflected. I'd also like to move for your attention to under expenditures. If you look at the line that says Budget Act of 2009 Program Expenditure and the 09-10 BCPs. Those BCPs that were approved were probation monitoring, but we did not receive any funding for those items, but we did get staff. So the funding for probation monitoring was absorbed within our budget. That is an ongoing function of the board, as you can see by the little dashes under each fiscal year. Operation Safe Medicine was an approved budget change proposal in 09-10, and that was a 2-year proposal that was approved. There was no funding associated with that proposal, but there was staffing. What we were told is that we needed to come back at the end of the time that we were running Operation Safe Medicine and come back with a proposed augmentation to our budget to request the continuation if in fact we could successfully prove the need for that augmentation. We have submitted that request for an augmentation to continue the operation of Safe Medicine, and you'll see that in the proposed 2011-12. So we are proposing an augmentation that will continue that at a level of 6 staff members, 4 investigators, a supervising investigator, and a clerical support for that unit to continue throughout the life of the board. If we should be able to demonstrate that there is additional need for staff to perform the Office of Safe Medicine functions, then we will request in the future additional augmentations. But at this point in time, that would be the only augmentation for continuous operation. Moving through the rest of the proposed augmentations for 2011-12, we have a BREEZE project. If you'll recall, we all spoke about the CRIMS project, which was going to be the computer system that tied the medical board to the Attorney General and updated all of our consumer information systems, our applicant tracking system with our master file system of complaints and investigation. That system was incorporated into the department's system that's moving forward, and the department got authority this year to move forward receiving funding in the current year, and that system we want to ensure works well with the medical board. So the proposed augmentation here is for a high-level staff person who is well informed about all of our systems to ensure that the integration of the medical board systems work within the entire system of the Department of Consumer Affairs. So that augmentation request is moving forward. The next augmentation request, the licensing support, if you will recall, we had a major budget change proposal, and that was approved by the governor. It's in this particular budget that has not quite been signed, but is moving forward, but it's been approved by all of the interested parties, the legislature, as well as the governor. And that licensing budget request provided us with 7.8 positions in our licensing division, and we have basically filled all of those positions. What we did as we were moving through this past year is we actually created a new system, which is a very important system that provides wonderful information to our applicants, and that's called our tracking, or WAS, which is the system for an applicant to go online and find out if all of the documents or what documents have been received by the board. It's immediately logged into the system, and then the applicant knows what is here and what is still missing, so the applicant can follow up with the original sources to ensure that that documentation gets to us so we may issue that license in a timely manner. So we proposed a staff person for that, and also a staff person to do the scanning of all of the documentation that is coming in on the applications, so we have easy access to that, but also so we can reduce our paper that sits around the office and ensure that we have a reasonable amount of space here, but also we can access the information in a very fast period of time. The last item that we're going to be, or we are requesting for an augmentation, would be our temporary helpline item for our district medical consultants. Last year we focused on licensing, and we did not focus as much on enforcement, although the department did in terms of the Consumer Protection Enforcement Initiative, and that will be discussed in greater detail when Ms. Threadgill gives her presentation. The department's initiative was looking at the front end part of our review of complaints to ensure we speed up the process to come to resolution whether that complaint should move on to the field or should be closed to take care of our consumers. What we didn't focus on was the important part that we work on, of course, in our investigation area. And we have many medical consultants that we've hired over time, and we have found that we do not have enough money in our temporary help item because these consultants are what we call permanent intermittent. So although they are real employees of the board, they're funded out of the line item called temporary help. So we want to augment that line item to ensure that we are able to spend the appropriate number of hours addressing all of the complaints that we have to review in the field to ensure consumer protection in an expeditious manner. So those are the augmentations that we are requesting. I did meet with our budget subcommittee, Ms. Yaroslavsky and Mr. Zerunian, to review these so they are well aware of those issues. So I just wanted to bring that to your attention so you understand how we propose to expend our money in the future. With these augmentations, that really will address some of the funds in our in our reserve, and thus we have not come forward with any proposal to reduce our fees, to lower our reserves, because we're coming forward with requests for augmentation. Are there any questions on the fund condition? We also have in here a number of documents regarding our expenditure, budget reports. If you have any questions, I will be happy to take those. Otherwise, I will move on to staffing.
Please.
Moving along to staffing, Ms. Threadgill again will address the staffing in the enforcement program later on in our agenda today. We still are at a very low vacancy rate, so we're excited about that. And she will also address our progress in hiring the positions for the Consumer Protection Enforcement Initiative, those positions becoming available this year as well as next year. The licensing chief, we have gone through our first round of interviews, and so that person should be on board sometime late August or early September if all runs smoothly. We also have either filled or identified all of the staffing for our licensing reviewing staff, so that's in the U.S. and the IMGs, international grad staff. And then we do have some positions that are still vacant in the executive area. As you know, the deputy director position is currently vacant. That position will remain vacant because it is helping to address our salary savings. It's a major assistance to me, yes, but at this point in time, I feel it's more crucial to ensure that we have the positions filled in licensing and enforcement. With my knowledge of administration, I have taken on many of the duties of the deputy and will continue to do that until we are able to fill that position, so we ensure that we have the salary savings that's required by law. The next item is the strategic plan, consideration of a 2011 update. This has been we're working on a calendar for 2011, and I will come back in November with an actual plan in terms of the timing during 2011. I know that we will have some work to do on that. We will have assistance from the department who has come through their solid division and volunteered to be of assistance, and we will be able to set up a committee. I will be working with the president on that particular effort. The next item is the potential board meeting dates for 2011. If you could all turn to item, let's see, lost the page here. Thank you. 148. Thank you. These are dates that we have proposed. These dates were proposed to allow us to look at some options. We also still have constraints in terms of our budget, so we put Sacramento in a couple times. As you know, the reason we're meeting in Sacramento in July, and the reason I made sure that the weather was really nice for you this time is so you'll come back in July, is that we do not have a budget in normal cases, a signed budget in July. So for staff to travel and for us to contract with facilities, it's most important that we be here in Sacramento in July. So we've identified those dates, and those dates also are consistent with the terming out of board members board members, even though their term ends on June 1st, if they're not replaced, they have a 60-day grace period, and so we're allowed to keep the board members on. As an example, Dr. Gitnick is here with us today because he's still within his 60-day grace period. So it's very important for the board, especially important should we have any quorum issues. So we need your direction and discussion of these dates, if they conflict with anything, because we need to begin to move forward at least with our January, February board meeting, and the rest we could put off in terms of your decision, but I would like to have some discussion on that, please.
Could we give you email feedback in the following week just to check other meetings that could be on our calendar that we don't have with us?
I think that would be a good idea. If I could ask the board members to please direct an email within this month, let's say, to our executive director as to preferences, if you have, or if there are no objections, it would be best to just let her know that you have no issues with either location or the date. I would appreciate that. Okay. I would give people until the end of the month.
Okay, and then basically based upon the information received from board members, you're directing me to go ahead and make a decision on that and move forward with the January or early February meeting. Is that correct?
Yeah. What we're asking is that you'll have a meeting on either one of these calendar requests from your staff, from you, and we will get back to you if there's any issues. If we have any problems with either one of these dates, please let Ms. Whitney know directly. And if you have a preference as to location, or you have no problem or no preference, please let her know that as well. Okay?
Moving on to E, the Bureau of State Audit's evaluation. As you heard from Dr. Gitnick and those of you who participated in the Division of Licensing meeting, you heard the discussion regarding an overall review of the medical board. As we've seen in the past, we've had a review of the Division of Licensing that was a specific focus review. We're currently undergoing a board evaluation, but it has a specific focus too. And so I'd like to continue pursuing the idea of an evaluation similar to the one that is done with the Bureau of State Audits for the State Bar, and bring this back to you at your November meeting to give you some very good direction on how we might pursue this. And as I mentioned to the Division of Licensing, that would be looking with assistance from medical consultant, our board president, and working towards coming back with what we really need to look at in a systematic way over time, so we can continue to have an assessment of what we're doing in this board as well as what staff is working on in our different divisions. Okay. Then the last thing I would like to mention, and it was handed out, is that I gave you all a copy of the executive order from the Office of the Governor. The executive order has to do with Fridays, the office being closed the second, third, and fourth Fridays of the month. The medical board was not excluded in terms of the exclusions for departments, so Consumer Affairs was not listed in the exclusions. So we will be starting the second Friday of August, closing down until further notice from the governor. You all have a copy of the executive order. Should the budget be signed, that may change due to contract negotiations with personnel, the unions, the staffing, but at this point in time, I need you to be aware of the closing the doors on those.
Thank you. Thank you, Ms. Whitney. Are there any public comments from anyone? I have no public comment sheets, but are there any comments from any of the board members about any of the report that you've heard from Ms. Whitney? I see none. We're going to move on the agenda, and we're going to skip over number 12 for the moment. Okay. And we're going to move on to item number 14. I want to ask Terry Boughton, the Senior Program Officer, Health Reform and Public Program Initiative, to please come forward. Either one of these tables. Let me just introduce you as you're walking up here. She's the Senior Program Officer for the State Health Policy for the Foundation's Health Reform and Public Programs Initiative, based in Sacramento. She works for the Foundation's liaison to policymakers, sharing information on policy developments and market trends, and support statewide efforts to expand access to affordable care and coverage. Ms. Boughton was most recently Senior Program Officer in the Foundation's Market and Policy Monitor Program. More than 15 years of experience in the legislative and executive branches, as well as the local government level. She's managed major health initiatives for the governor's office and the legislature. Prior to joining CHCF, she was the chief consultant to the State Assembly Health Committee, and earlier served as the Assistant Secretary for Legislation and Programs in California Health and Human Services Agency. And thank you for being here today to speak with us.
Thank you. Do I need to push? No, sounds like it's on. Okay. Thank you. It's a pleasure to be here. Good morning to you all. It looks like you have copies of the PowerPoint that we prepared. I did want to let you know, you had a great introduction that the staff prepared, but the California Healthcare Foundation is an independent nonprofit philanthropy based in Oakland, as you heard. Our goal is to improve the healthcare finance and delivery system. And as was mentioned, I work out of our Sacramento office in a government affairs role. And I'm honored to be invited to come and give sort of a brief but comprehensive overview of the Patient Protection and Affordable Care Act and Healthcare and Education Reconciliation Act of 2010. I will refer to it as the Affordable Care Act, or ACA. I want you to think about the health reform in three big buckets before I get started. First is health insurance reform and the impacts to people who purchase health insurance, either individuals, employers, small groups. The second is impacts to the Medicaid program, another big area where the coverage expansion takes place. And then the third is impacts in the Medicare program. As you all, I'm sure, heard much about when the bill was signed, the bill promises to expand coverage to 32 million people by 2019. And in California, we think that that means that up to 2/3 of our uninsured could be covered through this law. The promise was that the cost would be $938 billion over 10 years, at the same time reducing the federal deficit by $124 billion. I want to go over some of the major provisions. First of all Americans are required to have health coverage. There are some exceptions to this for purposes of religion, financial hardship. If you're incarcerated or an undocumented individual, you're not required to have coverage. There are tax penalties associated, imposed on individuals who are required to have coverage. There are also requirements to create health benefit exchanges. And what these are places where people can go to purchase health insurance. And it lays out the insurance options in ways that people can make informed choices, apple-to-apples comparisons of the products that are available to them. There are minimum benefits required. And also the health insurance exchanges are responsible for administering subsidies. So individuals who have income between 133% to 400% of the federal poverty level will have subsidies to help them purchase health insurance. And that equates to about income of up to between $30,000 to almost $90,000 annually for a family of four. There are also limits on cost sharing associated with products that people will purchase in the health insurance exchanges. And as I mentioned already, major expansions in Medicaid or Medi-Cal in California. there are maintenance of effort requirements imposed on states so that they cannot substantially reduce their Medicaid programs or children's health insurance programs, which would be Healthy Families here in California. So this adds to the budget challenges that the governor and legislature are dealing with. There are required increases in Medi-Cal payments to primary care providers that the incremental increase will be federally financed for 2013 and 2014. And back to the insurance market reforms, there are requirements that insurers cannot institute pre-existing condition requirements. They have to offer coverage to people who want to purchase. They have to renew policies for people who want to renew, and there are limitations on the rates they can charge. There are also new requirements on employers. Large employers are required to offer coverage to their employees, and they could face penalties if their employees try to purchase health insurance in the exchange. Small employers are encouraged to offer health insurance, and there are tax credits available to them to help offset the costs. And in terms of health insurance reforms, I wanted to mention that for those of you who have children, say, in college that are still on your health insurance policies, they will be able to remain on those policies through age 26. There are several changes in the tax code, again intended to enforce the individual mandate, but also to, oh, there they are. I think I'm on slide 5. Again, tax changes to enforce the individual mandate, but also to help pay for the subsidies and the program expansions, much of it federally funded. There are changes in the Medicare prescription drug program intended to address that donut hole gap coverage so that folks who are in that situation have access to drugs. And there is the creation of a temporary high-risk pool, which is essentially a place where people with pre-existing conditions can go purchase health insurance. And this is, again, a temporary measure until the insurance mandate and reforms take place in 2014. There are also a series of provisions intended to promote wellness and access to preventive services and treatment. Nationally recognized guidelines will be required in the health insurance exchange as well as Medicaid and Medicare with no cost sharing. There's also a new voluntary contribution for home-based long-term care services, and this will be an automatic contribution that folks will make through payroll deduction unless they opt out. And this will go to cover a new national program on home-based services with the idea of keeping people out of long-term care. And then several provisions to address the healthcare workforce, and I'll talk about those in just a moment. Slide 6. And I wanted to focus in and call out some provisions in the Act that are intended to address some of our ongoing challenges in the healthcare system. Who's gonna treat all of these new expanded people? There's an emphasis on primary care providers, and as you see in this slide, there are several programs listed and loan programs, scholarship programs, grant programs that are all intended to increase the supply of primary care providers. There are changes in graduate medical education funding to allow for reimbursement for outpatient residency experiences, as well as redistributing residency slots in hospitals where for a 3-year period the slot has gone unfilled. It will be redistributed with a preference towards rural hospitals or hospitals with low resident population ratios. The primary care extension program is intended to promote best practices in primary care, and there are changes in advanced practice nursing with grant opportunities for schools of nursing, academic health centers, and other accredited university programs to provide primary care nurse practitioners or nurse midwifery programs. I'm going to skip over to the next slide. And here, again, the problems of the growing costs in the healthcare system. And I just wanted to call out a few of the provisions in the Act that are intended to address growing healthcare costs. The first is the Medicare Center on Innovation, which is to affect Medicare and Medicaid. And the idea is to research, develop, test, and potentially expand nationally new payment and delivery models. And the idea is to improve quality and reduce costs. Accountable care organizations are a model of care that is being talked about, and there are demonstrations in both Medicaid and Medicare to promote the integration of care between outpatient and inpatient providers, again with the goal of increasing quality and reducing costs and sharing the savings associated with that better care. The Independent Payment Advisory Board is a Medicare board that is intended to develop recommendations to reduce costs in the Medicare program. And the idea here is that should the growth rate reach a certain level, these recommendations will become adopted unless Congress adopts other alternatives. And then comparative effectiveness research. There were investments in comparative effectiveness research, which essentially is comparing two or more treatment options for a particular condition so that patients and physicians can weigh the risks and benefits of the different types of treatment options. Again, investments in the economic stimulus package, more funding investments in the Accountable Care Act, as well as the creation of a private nonprofit board to administer the research. And then I wanted to call out a few other provisions for you in terms of medical liability reform. The Act establishes state demonstration programs to evaluate alternatives to current medical tort litigation, and the Secretary of Health and Human Services will annually submit an annual compendium of state reports to the Congress. Prevention and screening, I've already mentioned the mandated services with no cost sharing. Transparency and program integrity, there are a few things I wanted to call out for you here. Beginning in March 2013, there will be reporting requirements placed on drug, device, biologic, and medical supply manufacturers regarding gift payments and other transfers of value to physicians and teaching hospitals. And there will be fines associated with violations of that reporting requirement. There also exists a Medicare Physician Quality Reporting Initiative, and in this program there are payments associated with reporting certain quality measures. This is a voluntary program through 2014, but will become mandatory in 2015. And then just a few others. There is a prohibition on Medicare participation by physician-owned hospitals. If physician-owned hospitals do not currently have an agreement with Medicare for participation or don't have one by December 2010, they will not be able to participate. There are some exceptions. I'm moving on to the next slide here. This is a timeline, and I just wanted to call out for you that some of the provisions in the Act are in effect now or will be by September 2010. The bulk of it takes place in January 2014 when the insurance mandate kicks in and the Medicaid expansion. And then I'm going to skip over the next 3 slides for the sake of time and talk for a moment about the long-range impact in California. We think 2 to 3 million people will be newly enrolled in the Medi-Cal program because of the program expansions. That's a 25 to 35% increase in the population served in the Medicaid program. We also think 3 to 4 million people will gain private insurance in the private marketplace because of the insurance reforms, because of the mandate, and because of the subsidies. but we will still have 1 to 2 million uninsured in California. And as you all know, because of the budget deficit, the growing costs of health care, there are going to be many challenges associated with implementing this health reform and challenges ongoing to our healthcare system. There's a lot of work to do to prepare for 2014. We have to get started now. And in order for it to be a success, we think communication, coordination, creativity, accountability, all will be key to its success. And with that, I'm going to stop and try to answer any questions you may have.
I have one. Well, you know, according to American College of Medical Schools, at this moment, without a healthcare reform, we have a 15% shortages in physician in general. Now, we're not going into primary care portion. So with this item added into it, it's about another 15% people who are not insured additional will be into the system. So in my books, there's about 30% shortage of physicians nationwide. I was looking at what they're doing. It doesn't seem to have a lot of money going into retraining the physicians and all that. What's the plan for California in your mind, and what is the situation like as far as the physician shortage?
Well, there are certainly many challenges on that front, and it will take a while to train and produce more physicians, and may not, work out in the time period that we need them. As you mentioned, we're already in a severe shortage now in some places. One of the things that I think people who work to try to solve these problems are thinking about is ways to use less skilled providers to do some of the things that that physicians, with supervision could work with physician assistants, nurse practitioners, and other providers to help address some of the primary care needs. Telemedicine is another opportunity we have to really connect people in areas with who are underserved and don't have access to the specialists or to providers they need in those areas, to make those connections, to allow for more training and better relationships. There are many people working on trying to develop answers, and again, it's one of those problems that is ongoing and isn't fully addressed in the health reform law.
Dr. Gitnick?
This is not a facetious question. Is there any organized effort within the state to address delivering health care, assuming you're correct and only 2 million people will be without insurance, assuming that it's only 2 million? Is there any organized effort to address the needs of those 2 million people?
I think I don't know if I would quite say organized effort, but the state is in the process of negotiating a Medicaid waiver with the federal government, and there's a big emphasis in the development of the next round of that waiver on preserving the safety net for exactly that purpose. To help to make it available as it currently is for those uninsured.
Thank you. Dr. Levine?
A question and a comment. The question, Terry, you mentioned that the increased Medi-Cal payments to primary care providers is funded by the federal government in 2013, 2014. Is there a requirement for the state to maintain that effort after that, or is it up to the... So depending on the state's ability to do that, the rates either stay at Medicare or fall back to a state rate. Is that correct?
That's the way the law reads now. I think some folks anticipate that there will be pressure for additional federal funding beyond those years, but that's not in the law currently.
And Gary, to your question, the consortia of federally qualified health centers and 340B providers are actively working on this issue. There is money in the bill for the FQHCs, I think intentionally to support maintenance of their efforts in taking care of those who are not eligible under the ACA Act.
From a practical point of view, Sharon, does that mean that the resources will be available to provide health care to 2 million or more uninsured?
Well, will there be enough? I don't know, but there is a substantial amount of money that's been $11 billion federally that has been dedicated to the FQHCs and 340B providers. Will that be enough? But it's an acknowledgement of the fact this bill didn't envision 100% coverage.
I think that what we need to all do is to take a deep breath here and realize that planning for this is what's going on currently. That we applaud your efforts and your efforts to inform us, and we thank you for that. But I think that what we all need to realize is that there's a planning process, that it's not going to happen tomorrow morning, that we're going to wake up and everyone's going to have coverage and everyone's going to have a doctor and everyone's going to be reimbursed. But I think that the message needs to be constantly on the forefront, that reimbursement for services provided, medical professionals to be able to provide the service, and the people to avail themselves of the opportunities need to be as a collaborative opportunity as we go forward. And this is going to be all new to every one of us. So thank you for your efforts and thank you for your presentation. And let me just ask if there are any other questions.
I would just make one comment. I think that just as a lot of providers are preparing for this, the medical board itself, I think, should be proactive and ongoing look at how all of this might impact what we're about going forward, consistent with everybody else. And so I hope this is not the last time we have this discussion or this review.
Thank you. I ask that you wait just a moment, make sure I don't have any public comment and any questions for you publicly, and I don't see any. I haven't received any slips. But I want to also thank you again for being here today and hope you'll return in the future with any further updates and some good positive information to share with us. Thank you. So I'm going to return to item number 13 and ask for I want to, I have to tell you something. I feel it's important to do this, that we have members of the board that are not here today, and they're not here because they didn't feel it was important to be here today. One that had a very ill patient that he had to see, and one who had a daughter who is going off to college. And the same as now, staff is coming forward, and I thank you, Mrs. Mose, for being here. And I'm going to ask Ms. Whitney to participate in this conversation as well. Mr. Shunke, who we are all very much appreciative of his energy and efforts, had surgery this past week and is not able to be here today. And it's not because he didn't want to be or he doesn't feel passionately, and I just wanted staff to be aware of that. Staff, for us to be aware, sorry. So we're going to move on the legislation agenda. Ms. Whitney and Ms. Smoes are going to double team us on two sides of the aisle.
If you will all turn to page 150 of your agenda packet, basically gives you the status of pending regulations. The one thing that I do need to note that came up after this was published is that the disciplinary guidelines have been withdrawn at this point in time because there were concerns about some of the materials in that regulation packet that the consultant at the Office of Administrative Law wanted to discuss with us, and we didn't have that opportunity before the deadline date. He only notified us a couple days beforehand. So we withdrew those. We will be working the first week of August on getting all of those concerns addressed. Legal counsel will be meeting with staff as well as the consultant from the Office of Administrative Law to make sure we've addressed all of his issues so we can resubmit them within the time frame set by law. Are there any questions regarding the regulations? Thank you.
All right, the next agenda item is legislation. Please refer to your legislative packets. The first page of your legislative packet is the tracker list. I've categorized the bills by color. I'll just quickly go over that. The gray bills are the dead bills, and these are the bills that have not passed the deadlines, and they're no longer active. The white bills are bills that the board has already taken a position on and have not been amended since the last board meeting. The gold bills are bills that the board has taken a position on and have been amended since the last board meeting. However, the amendments should not change the board's position. Do any of the members have any questions on any of these bills in gray, white, or gold on your tracker list? Okay, seeing none, I'll move on. Okay, I'm going to move on first to the bills in pink, and these are board-sponsored bills. The first one is AB 1767 Hill. This is the bill that has to do with our expert reviewers. The amendments that have been recently taken were DCA requested amendments they were basically clarifying amendments, but the language was also added that extends the sunset date of the board members of the Health Professions Education Foundation. So that language was added, and the sunset date was extended for 5 years until January 1st, 2016. That bill is moving through. It's actually on the Senate floor. We anticipate no problems. It passed through on consent in several committees, so it's moving through nicely. The next bill is SB 1489. That's the omnibus bill. It's the Senate Business and Professions Omnibus Bill, and the provisions of the bill that impact the medical board were pretty technical in nature. They delete obsolete references to licensing exams. It was recently amended to include the reporting requirements for midwives and clarifying amendments that the board approved, and those were amended into the bill. That bill is moving through the process, and it will be heard in Assembly Appropriations next week. Does anyone have any questions on those two board-sponsored bills?
Questions? No.
No?
I think I have a
question?
Did you say something about you're not covering all the others, the white ones?
The white ones have not changed since the last time the board approved positions, since the last board meeting. The gray ones are dead. They're no longer active. They've died because they didn't pass the deadlines. And the gold bills are bills that the board took a position on the last meeting, but they were amended, but the amendments should not change our position. I'll be happy to discuss any of these bills if you have questions.
Well, I would like to request to look at the AB 2600.
Okay.
The hepatitis bill. So, right. Just to see whether the board would reconsider its position.
Right now we have a neutral position on that bill.
I realize that.
Okay.
So are you asking Ms. Simos to go review 2600 and for us to have a discussion on that? Is that what you're...
Yeah,
okay, so would you like to, everyone turn to AB 2600 and let's hear a brief overview of it, please.
Okay, AB 2600, it's currently in the Senate Appropriations Committee. This bill would require the board to consider including a continuing education course in the diagnosis and treatment of hepatitis. The board previously took a neutral position, and the bill language is directly behind the analysis.
I think that the concern of Ms. Chang is similar to one that we all have given what we heard yesterday. But I am going to suggest that we don't look to change our position, because as important as this is, in my opinion, and it is very important, if we're going to start mandating CME credit and education on the diseases that are involved with patients in the state of California, I think that we're going to run into a situation where we are not going to be as successful as we think we might be. I think that currently there is a tremendous need for education. We heard that yesterday. I think that we need to actively participate in trying to figure out how to get that message out. So I'm not sure where we're going to go, if it's going to be through the Education Committee or through the Access to Care Committee. I just want to everyone to realize that this is not an issue that's going to be reduced by not taking a different stand on this bill, and it's not going to go away because I really feel a commitment to being engaged personally, whether it's an active piece of legislation or not. So I just want to caution members that when we start to take a look at what we are going to mandate as far as CME goes and the success of what the outcomes are for CME and who is going to be taking the CME that we're going to make a difference with, what change are we going to affect in public policy in the state, I'm not so sure that we are not marginalizing what we're trying to achieve. So I'm trying to say that is, okay, thank you, Dr. Levine.
I absolutely agree with you. I think the easy solution is mandatory 1 hour during your career of CME in X. The problem with that, and I think, is that there's no evidence, number one, it changes behavior or changes practice. It becomes a compliance function rather than what we talked about in the Education Committee yesterday, which was really a broader and more thorough approach to understanding what opportunities we have to create demand for better information on the part of patients and physicians, and really engage the tools of a social marketing campaign to raise awareness of the issue across the state. And I think a lot of interesting ideas were raised yesterday, and I suspect there are a lot of allies out there that the board can work with in terms of really raising the issue to the level of importance it requires. I support your position completely, and I think we should be neutral on the issue of mandating certain CME, because to some extent it provides a false sense of, okay, we took care of that.
Exactly.
It's over. We don't have to worry about hepatitis C or hepatitis B again.
Exactly. Does anyone else like to address? Does anyone else want to address this, Ms. Chang? Do you want to say anything?
I'm just raise the issue for discussion.
No, absolutely. It's a good idea. Thank you. I appreciate that. Anyone else? Okay, continue, please.
Okay. So I'll move on to the bills in blue. These bills are bills that have not been brought before the board before, and that the staff is recommending positions. The first bill is AB 2386, Gilmore, and there's an analysis and a copy of the bill in your legislative packet. This bill will allow non-military hospitals to enter into an agreement with the Armed Forces of the United States and would allow them to authorize a physician assistant, or registered nurse to provide medical care. The physician would have to hold a valid license in good standing in another state if the medical care must be provided as a part of training or educational program designed to promote combat readiness, and the agreement has to comply with federal law. The bill does contain some consumer protection provisions. The bill requires a physician to wear a name tag that includes his or her name and license status, his or her state of licensure, and the statement that he or she is a member of the Armed Forces of the United States. The bill also, the physician would also have to provide information to us on a form so we would know that they're practicing in these hospitals in California. It is allowing an expansion of allowing people to that aren't licensed in California to practice, but under very narrow conditions. Staff is suggesting a neutral position on this bill.
I'm hearing a question. I have a question. I'm hearing from you that this is military?
Military only, yes.
I'm not reading.
Military physicians.
This is AB
2386.
I'm reading the wrong bill.
Sorry.
Continue. I apologize.
Okay.
Is there any questions on?
Just a comment. It's already true that if a doctor practices on a Veterans Administration medical center property, that doctor does not have to be licensed in California. And there are many VA doctors who are not licensed in California.
Yeah, this is correct. We would just expand that to non-military hospitals.
So you're going to suggest that a military doctor who does not have to be licensed in the state of California, who currently may practice in a military hospital, be allowed to go to a non-military hospital for training purposes only. Is that what I'm hearing?
Yes, that is correct. It's only for training purposes in an educational program designed to promote combat readiness.
So we're not going to be bringing in military hospitals into community hospitals to practice medicine.
It would be narrow. It would be very narrow.
I just want to clarify for everyone sitting behind the horseshoe here. Okay, thank you very much. Do we have any questions? Okay, go ahead. Do you want a motion
So the
to?
position that staff is recommending is a neutral position.
Okay, so I need a motion to. So moved. Okay, all those in favor? Any public comment? Look, I don't have any slips, so if I don't have any slips, am I supposed to still ask?
Yes.
Okay, I apologize. Then I apologize. I would not want to mess up with the procedures. Is there any public comment on that position? Is there any comment from any of the members? Okay, all those in favor?
Aye.
Any opposed? Okay, so number 2386, AB 2386, so therefore passes. Okay, next one.
Okay, the next bill is AB 2699 Bass. This bill is sponsored by the Los Angeles County Board of Supervisors and would allow physicians from other states to practice medicine in California without being licensed under specified circumstances and for purposes of special events. An example, this is the RAM event that takes place at the Staples Center. The last event was conducted in August 2009. Volunteer healthcare practitioners provided free services to over 14,000 patient encounters during this event. The bill currently in print would exempt healthcare practitioners from California state licensure if they are licensed or certified in good standing in another state, district, or territory in the U.S., and if they provide healthcare services under specified requirements. They would have to submit to the medical board a copy of their valid license and a photo ID. They must provide services to uninsured or underinsured persons on a short-term voluntary basis, no longer than 10 days per sponsored event. The services must be provided in association with the sponsoring entity that has to comply with specified requirements, and the services must be provided without charge to the recipient. They would have to register with the appropriate licensing board, so they would have to register with us on a form that includes specific information within 15 days of the provision of health services. And the sponsoring entity must maintain a list of healthcare practitioners associated with providing these healthcare services. Staff is suggesting that the board take a neutral if amended position. Staff believes that we should work on amendments to put oversight of this registration of the sponsoring entities under one organization instead of it being with each individual board. In that way, that would prevent any differing requirements from different boards or differing ways of how these forms are handled. We also, the bill right now, the bill in print uses the word revoke, and we're suggesting that instead say rescind because revoke has a legal meaning. And we also think that the sponsoring entities should be limited to nonprofit entities. Cheryl, I believe what you have is a handout of the bill may be amended on Monday in Appropriations Committee. You should have a copy of the Ledge Council amendments. Look like this. And the reason why I'm not going too much into what the bill does now, because it will substantially change if these amendments are taken on Monday. Do you have one? Okay, let me.
Okay, so could you generally give us an overview of the amendments? I would appreciate that, please.
Yes, I will. The major amendments, what they do is they change it from a registration program to basically a program where each board would authorize these differing practitioners to practice medicine without a license. So we would be saying we, the medical board, are authorizing these practitioners to practice without a license. There would be more requirements for us to collect more information, to charge a fee for this processing the forms. The terms, and one of the issues is the terms would be decided by regulations by each different board and bureau. So the terms for revocation of, or terms for limiting or taking away the sponsoring entity's registration would be set by regulations by each individual board and bureau. The fees would be set by each individual board and bureau and regulations. So it could be one fee for the medical board, but a different fee for another board. Staff has concerns with these amendments. Number one, with authorizing, giving our stamp of approval for these practitioners to practice without a license in our state, instead of merely, we're taking their information and registering them and saying, we have their information. If a complaint comes, we can send it to the right state. Giving authorization is a term that we're more approving them, giving them our approval to practice medicine without a license. And so we have concerns. Like I said, I'm not positive these amendments will be taken on Monday. Something different could happen in committee, but I would like your direction to go and testify and relay any concerns the board has.
Could I offer some additional concerns from a legal perspective? With the bill as it is currently written, there are issues raised about enforcement and the ability to obtain patient records. We also noted that there's no limitation, although there's a time limitation on the length of the event, there's no limitation on the number of events per year that an individual could participate in. And it would also be better if it were clear that there was no payment to these physicians. Volunteer is a very loose term.
Okay, so I'm going to suggest something. I'm going to hear from each and every one of you. I just have to tell you that I feel I have some very strong opinions. Normally I would speak last, but I just want to correct a little bit of what we've heard so far as to my knowledge, and you'll correct me if I'm wrong.
Okay.
The first event that RAM had, they did have at Staples Center, which is a major entertainment center and sports arena in Southern California. The lines were horrible, horrific, and long. The need is great, and the need, I can't tell you how it pains me to have to go where I'm going to go with this. But there was no verification, there was no knowledge, there was no expectation of who was delivering the service, and in no offense to them, I don't know who they are. I mean, it doesn't, and it's irrelevant who they are. But I personally have an issue with the chance of separate or different services regardless on ability to pay, regardless on ability to have need, that I cannot ever support, no matter what the circumstances are, for someone to receive medical care that might not be up to the standard of those that can afford to pay or those that might have insurance or that those that have no need. So that's number one. Number two is they came back and they did another event. So I don't know that this information is part of your information. And they did it at the sports arena, which is a little smaller facility. It's in a Joint Powers facility very close to USC. And this time the request, to my knowledge, was, and in the advertisement was, that they be licensed California medical providers. And at that point, the need was just as great, the lines were just as long, and the services were provided. And I have to tell you that I didn't have a problem. But I have a problem realizing, and I've seen what happens in the Federation meeting for the short meeting that I attended, that the standard of practice and the standard of licensure is different state by state by state by state. The idea that someone can come in and have an exam with no medical records, that those medical records go nowhere, that there's follow-up and there's no follow-up, there's no ability to have that opportunity and to put our agreement and our stamp of approval on it, I personally feel that it's morally bankrupt. I can't tell you how strongly I feel about this. So on that note, I'd like to hear from the rest of the board. And I apologize for going first. I would really rather go last, but I want to make sure that you understand that I'm going to have a major problem with this one.
Dr. Dean. Yes, ma'am. Registration doesn't address the issue of verification of what's registered. Is there any provision in here for verification?
Well, in the amendments, I believe that other than getting a copy of their valid license with a photo ID, I mean, that's the form of verification.
Well, I can only echo what Barbara has said regarding this. I mean, I feel that it is very different provision. I mean, the follow-up, the medical records, and here we have this new bill or law that's in effect beginning, June or July, that we need to post every California physician that your care is regulated. So what about these physicians? Are we then saying they can report to us about them, or there is no accountability? I feel that it sets us up totally for a two-tiered care, and I wouldn't think there are enough amendments to make me feel comfortable. I would have to vote to oppose this bill and instead look to, again, let our our California physicians become volunteers, which, again, we're working with the liability issues, and I think that that's the direction to provide the care and not have this new registry category. I think that's a very dangerous concept for patients. No patient protection in that.
Dr. Gitnick.
Traditionally, this board has opposed two levels of care for Californians. Although I think we're devoted to the concept of delivering health care to indigent people and finding ways to do so. The Steve Thompson program came out of an effort by our legislature to allow physicians trained in Mexico who did not meet the licensure standards of our state to provide health care to indigent people. And then out of that developed the Steve Thompson concept, which also provides health care to indigents. The concept of saying that rich people get fully licensed doctors, but poor people get doctors who don't measure up to the requirements of that licensure is anathema. It's wrong. Everyone in California should get excellent health care from fully licensed doctors, and I would join in opposing this bill.
Do you have any comments, Ms. Chang?
Well, I'm joining in opposing also. There are states in the United States does not have CME requirement after they pass their test. And there are states who accept 100% of the Caribbean schools, and with no exception. Every one of them are accepted in their state. So the quality of care is just so different. So I'm objecting to it just the same.
Okay, so I'm going to ask for a motion one way or the other.
So move to, I move to oppose this bill.
Do I have a second?
Second.
Okay, do I have any public discussion on the bill and the motion to oppose? Okay, do I have any comments from the board members? Call for the vote. All those in favor of voting to oppose, what is it? It's AB 2699. All those in favor of opposing the bill?
Opposing.
Aye.
Aye.
Any opposed to opposing? If that means a double negative is a positive. Anybody supporting? Okay. So any abstentions? None. Okay. So your direction is that we are opposing this regardless of amendments. Okay.
I got it. Sounds good.
The issue is license in California.
Okay. Thank you.
Okay, so that takes care of the two new bills, and I just wanted to bring one bill that's in green to your attention, SB 294, Negrete McLeod. This bill changes the sunset review dates on various DCA regulatory boards and bureaus, including the Medical Board of California. What it would do is just change the sunset date for the Medical Board from 2013 to 2014. We don't really need to take a position on this bill if that's the board's will. I just wanted to bring this bill to your attention to let you know.
Okay.
Unless you want to.
Any comments? Any public comment? I would just go on as you've been doing. Fine.
Okay, and actually that concludes my presentation unless any board members have questions on other bills that we did not discuss.
Thank you very much. I'm going to ask that we take a 10-minute break. It's now 10 minutes to 11. I'm going to start this meeting at 11 o'clock, and that's, thank you for your patience. Okay. We are going to move to our committee reports. And so we're going to move the agenda to item number 13. Oh, I'm sorry, 23. Item number 23, with the Enforcement Committee update and consideration of committee recommendations. Dr. Lowe, could you make a report to us, please?
Yes, the Enforcement Committee update. The Enforcement Committee had their second meeting yesterday, and it was very productive. We presented 3 vision statements which are in your booklet, and the recommendation of the committee is that the full board adopt number 2. And number 2 reads that the Enforcement Committee will act as an expert resource and advisory body to members of the Medical Board and its enforcement program by educating board members and the public on enforcement processes and by identifying program improvements in order to enhance protection of healthcare consumers. So the committee would recommend to the board that they adopt this vision statement, and if they'd like to make some modifications, we're open to that as well.
So you're moving that motion, sir?
So moved.
Second, please.
Second.
Discussion on that motion as it stands, please. So, Dr. Lowe, how do you feel about taking the word expert out of there?
Actually, that was my suggestion.
Oh, well, I'm going to ask, okay, thank you. So, taking your motion as you've stated with an amendment to the motion, would you accept the amendment, sir?
Yes, absolutely.
Would the maker of the second also accept the change? Thank you, okay. Do I have any public comment on Dr. Lowe's report? Do I have any questions for Dr. Lowe from any of the members? So seeing none, the motion, all those in favor of the motion?
Aye.
Aye.
Any opposed?
So just to finish the report.
No, right, I appreciate
Okay.
that.
We received an update on the progress of the expert reviewer training. They made a site visit to UC Davis, and the medical school has offered their state-of-the-art training facilities, which will enable interactive training. And so the staff is now preparing the agenda for that expert training program, and it's targeted for the spring of 2011. And I think this will go a long ways to standardizing experts up and down the state. We also heard a review of the enforcement program so that we can have a better understanding of the division of responsibilities between the enforcement operations and the field investigation components of the program. The next training program will focus on the probation monitoring section and how the terms and conditions of probation are implemented. So each one of these committee meetings will have a focus session, so the next one will be on probation monitoring. And finally, Dr. Norcross made a presentation about the PACE program, which included the results of the 2007 audit of their program by the UC system, how they implemented those recommendations, and they gave a program status report as well. We heard about how the enforcement program determines whether or not the clinical education program is equivalent or comparable to PACE. That concludes the report from the committee.
Thank you very much. I'd like to move on to item number 26 and ask Dr. Salmonson to do a licensing committee report.
Okay, this will be a little more bureaucratic. Our licensing committee had its second meeting, and there are a couple of regulatory issues that we need board action on. The first is a regulatory proposal for a limited practice license. The committee voted to recommend to the board to direct staff to schedule a public hearing for the November 5th board meeting to adopt that regulatory language. So I don't know if we need public comment. Do we would like a motion to have the board direct staff to set the public hearing? Can I have a?
So moved.
Second.
Okay.
Is there any public comment?
Or board comment?
Any board comment? All those in favor of the motion?
Aye.
Any opposed? So you've got your hearing.
And the second is an analogous request, and this regulatory proposal is for polysomnographic technologists. And again, the committee voted to recommend to the board to direct staff to schedule a public hearing for the November 5th board meeting to adopt the regulatory language regarding the polysomnographic technologists.
So I have the motion to move that.
So move.
Second.
Is there any public discussion on that motion? Is there any board discussion? All those in favor of that, please say aye. Any opposed? So done.
All right, so we'll have a couple public hearings next meeting. Other ongoing items, Ms. Whitney provided an update on the application processing times for physician and surgeon applications and the business reengineering primary recommendations. Ms. Whitney also provided an update on the feasibility of a licensing program audit. Ms. Taylor provided an update on the training program for new licensing staff. And Ms. Humphrey discussed the possibility of adding a photograph to either the wallet ID and or the web for license verification. So the future agenda items will be the regulatory issues regarding the limited practice license and the polysomnographic technologists. And that was our full meeting.
Thank you, Dr. Salmonson. Is there, there's no public comment on your report, so I've heard. Thank you. Moving on to number 27, Dr. Moran, would you please make, we'll move on to number 28, the Wellness Committee.
Yes, thank you. The mission of the Wellness Committee is to further the board's goal of consumer protection by encouraging and guiding licensees to promote a sound balance in their personal and professional lives so that healthy physicians offer quality of care to their patients. And one of the avenues by which the committee strives to fulfill its mission is to help identify, assess, and share information on available resources. For the Wellness Committee to gain a better understanding of what wellness resources are available to California physicians, and with the support of the California Hospital Association, the California Association of Physician Groups, and the California Medical Association, developed a survey was created and published online during this past winter. And from the survey, it became obviously clear that many of the California large hospitals and physician groups already have established successful well-being committees, whereas many other hospitals have struggled to bring such programs in operation. Using the results of the survey, the committee will host a meeting in Sacramento on Tuesday, August the 17th, to start developing a best practice model for wellness committees, which can be used by other entities. And at the November board meeting, I will present the outcome of that meeting. Thank you.
Look forward to that. Thank you very much. Dr. Lowe, and would you present the Physician Assistant Committee update, and Ms. Portman?
Yes, Ms. Portman here. I think because we're out of sequence. Oh, there she is. Yes.
Could you come forward, Ms. Portman, please?
So I'd like to introduce Alberta Portman, who's the Executive Officer of the Physician Assistance Committee. She's done a superb job, and it's been a pleasure to serve on her committee. Do you want to give the report, or would you like me to? Okay, sure. Did you have any questions of Alberta, Barbara, or you just wanted to introduce her? Okay, good.
May I just take a moment to
Sure.
thank the members for all your support to the Physician Assistant Committee, and we appreciate Dr. Lowe serving on the committee, as well as Linda Whitney as a great support to our staff and the committee. Thank you.
Okay, so for a report from the PA committee, the executive officer briefed the committee on the status of the Consumer Protection Enforcement Initiative and implementation of the uniform standards of SB 1441. The executive committee, the executive officer, the committee, and the enforcement staff continue to implement improvements to the enforcement program, and it's much more timely now. We can shorten the timelines from criminal and arrest documents are directly forwarded to the Attorney General's office, and they don't have to go through the field investigation unit. So we're doing everything we can to shorten timelines. The committee continued to report on all disciplinary actions, including denials to the National Practitioner Data Bank, and for the past year, the committee staff has also checked on the data bank on all applicants applying for license with the committee. In terms of new regulations, the continuing medical education regulations were approved by the Office of Administrative Law on June 12, 2010. So now a notice has been sent to all licensees and the information has been put on the website. The CME requirements are 50 hours of continuing medical education every 2 years, or they can maintain certification through the National Commission for Certification of Physician Assistants. The committee also received approval for amending the citation and fine program, and so they deleted the list of specific laws and regulations for which the committee may issue a citation, and now the committee can issue a citation and fine for any violation of the Practice Act. In terms of proposed legislative changes, I mentioned this last time, other allied health committees have changed their name from committee to board. The only one that hasn't is the PA committee. So we're going to move in that direction. It's going to be twofold. First, the committee has directed the staff to work with the department legislative unit to seek an author to include the committee in the reporting requirements under B&P Code 800 series. After that's been done, then the staff will work with an author to implement changing the committee to board. So this should not affect the relationship that the committee has with the medical board. That concludes my report, and the next meeting for the PA committee is October 21st, 2010. Thank you.
Thank you very much, Dr. Lowe. Could I take a moment of your time, and could you explain to us a little bit about what you do or what your committee does, or who your people are, or what the PA system is all about?
The Physician Assistant Committee, we have about 7,500 licensees right now. We're licensing about 55 or 58 licensees a month on average. They work in all areas of the state. They were originally to serve underserved areas. Back in 1985, when the committee was first formed, it was to assist physicians in areas of California that had a lack of physicians. And so it's grown from then. And now we work in all areas of the state, in clinics and hospitals, and it's just growing. And with the new healthcare reform that we're seeing, we should see another growth in the PA population.
Could you tell me, because I don't, I'm new to this as far as that goes, what is the scope of practice of a physician's?
The scope of practices, they can, with their delegation of services agreement, they can perform any procedure that their supervising physician allows them to do, and if their training allows them to perform any procedure that a physician may do.
Under their direct supervision or under?
Supervision of the physician assistant, or the supervising physician, yes.
Does that mean on site, in the same room, in the same building?
It has to be within eyeshot or earshot in an operating procedure, but they can operate in a office setting. They can be, in another room. They just have to be available. The physician has to be
operating
available.
procedure? They're doing surgeries?
They can open and close surgeries, yes. Yes.
Does anyone have any questions of the executive officer? No? Sorry.
The PA committee has been extremely efficient in both the enforcement and licensing.
Great. Thank you very much. Thank you for being here.
Thank you very much. Thank you.
Okay, I'm going to move on to number 30 and ask Ms. Chang to do a report. I have to tell you that I think that we're very personally very lucky on this board to have one of our members serve on the Federation board and be willing to go out of state and travel and be there for us and come back to us and let us know what's going on. So I want to thank you personally for doing the work you do on the Federation board, which is, for those that don't know that much about it, it really is a federation of all of the state medical boards across this country, and California is a leader, but I want to thank you for being at the table and making sure they hear us.
Thank you.
You're welcome.
But I think also we have our own board members who are on every committees, and I believe Janet this morning is on a conference call on the educational committee for 2 hours.
Starting at 5:30 this morning.
Yes. And Barbara is on bylaws committee, and the meeting is coming up.
Okay.
And Dr. Marine is on the nominating committee. So whoever wants to run for board members and officers, they will have to go through her. I think Barbara went to the annual conference and we made a report on that one. And afterwards, the most current issue is the maintenance of licensure. The board has already decided, the Federation board has already decided, and with all the member board, which is all 50 states plus the DO boards, 70 boards has decided that maintenance of licensure for physicians is a very important issue. I happen to sit on the implementation group for that. They did a simple reports in the beginning, but we're hoping by end of next year, the next annual meeting, the whole issue will come out. And the document is being circulated. They are in 3 different phases and hopefully be implemented in 10 years. The first phases is the pretty much the CME phases, is to make sure all the CME requirements from all the states are practice related. That's probably the best word to put it. And the second phase of it is the assessment, which is a harder phase and will take probably 3 to 4 years to develop the program and to make it happen. And the third phase is actually sort of like the third phase of the 360 is actually patient and the user's evaluation. I don't know we'll ever get to that spot, but whoever has their certification of their specialty board in Federation's viewpoint meet maintenance of licensures requirement. And that's the biggest issue that is going to come out, and the past board chair, Marty, will be coming to make a presentation when the time fits, when this board wanted to meet with him. And on the other hand, I made it as a board member for the foundation of the Federation board. It's an educational foundation, and they had an election, and I was quite honored that they picked me and voted me in. So I think I did a good job for the California, otherwise they wouldn't have done that. Thank you.
Thank you very much for your report. Moving on the agenda to item number 27, Dr. Moran, would you please make a report to the board?
Certainly. This is regarding the meeting of the Advisory Committee on Physician Responsibility and the Supervision of Allied Healthcare Professionals. We met on June 23rd in Sacramento, and the goal of the committee is to discuss under what circumstances it's appropriate to delegate the performance of procedures, and if it's legal or appropriate to delegate to non-physicians the selection of patients and procedures, and if so, under what circumstances. Janie Cordray has been our staff member. She retired after that meeting, and Candace Cohen has now filled her big shoes, and I'm sure is going to do a fabulous job. So far, it's been a very productive group. During our tour meeting, we heard from representatives from many professional organizations, including Northern California Aesthetic Nurses Association, the American Society of Derm Surgery, the California Society of Facial Plastic Surgery, American Academy of Facial Plastic Surgery, California Society of Plastic Surgeons, the California Academy of Physician Assistants, the California Academy of Cosmetic Surgeons, and the American Nurses Association. Their interests and opinions were all represented at this meeting. The discussion was broad, ranging from supervision to training and education of physicians and mid-level practitioners that they supervise, to pending legislation and more. It's primarily an information gathering meeting with no action items agendized. We decided to discuss our next meeting the baseline issue of enforcement of existing laws and regulations, ways to improve some of them if necessary, and before we go seeking any new legal requirements or legislation already in law, we want to just make sure that we are fully enforcing those that we have available to us. At our next meeting, we haven't set that date yet, but it will probably be not on the same day as an actual board meeting. And in the meantime, we will be consulting with legal counsel the Board of Registered Nursing, and as well as enforcement, as well as other interested parties. Thank you.
Thank you very much, Dr. Moran. Are there any questions for Dr. Moran? Public comment? No, okay, thank you very much. For those of you that are following around on the agenda, understand that what I'm trying to do is make things happen with people not here. So we're really not going that much in order, but I'm trying. We've got time limits and time constraints for certain speakers and otherwise not. So we're going to move on the agenda. We're going to return to item number 16. And in Mr. Shunke's absence, I'm going to ask Ms. Whitney to make that report on the licensing outreach report, please.
Mr. Shunke wanted to give you a report, been there, done that, going back again. To be very quick and fast with his report. But what I want to say regarding his outreach activities is that I seldom see him in the office because he is out at hospitals, at the medical schools, at the postgraduate training programs. He is really out there working with our constituents, our important program directors, to ensure that we not only tell the medical students what is expected of them when they come into licensure, but also what is expected of the postgraduate students who are coming into their licensing application process, what they must fill out, what the timelines are, and what our expectations are. So he's been doing a fabulous job out there, and he's been connecting with some of our board members as he does travel to the local hospitals or universities that he's doing orientation or making presentations at. So he will be connecting with you, sending emails to let you know that he will be on site or near site. So if you have an opportunity to drop in and see what he does and what's going on during that orientation or the licensing fairs, he would love to have you join him on that.
Thank you very much. And Dr. Gittner?
Linda, I think you should commend Kevin. He's just doing an outstanding job. He's now known on every UC campus. He's beloved. He's just doing a superb job, and he's reporting to us on a regular basis in writing. It's so commendable. You've got to convey that to him.
Thank you. I certainly will. And he does apologize for not being here today, but an unexpected illness prevented him from being here with you.
Thank you. Would you also present number 17, please?
If you will all turn in your agenda packets to tab 17, and that was an insert page, so there's not a page number. And it has to do with the summary of expenditures on the governor's job creation initiative. This was a second sending, so if you have that additional information that we sent out with our legislative packet. Basically, the governor in early March implemented a job creation initiative where he allowed the boards to spend additional temp help monies funded out of the operating expenses that were held in reserve to ensure that we cut our pending license application review time in half, and also the pending files. And so this is a summary that you have here of the expenditures in terms of overtime and temp help. The overtime is representative of your staff coming in on weekends and spending 10 hours per day instead of a normal 8 hours per day to ensure that we met the governor's initiative. And the temp help represents putting into place those 7.8 positions earlier than we were really authorized as of July 1st. And making this a team effort throughout the medical board to get this done. So the expenditures aren't great. They're $113,000 out of your budget of $52 million. But what it represents is a huge team effort and a commitment from your staff throughout the board of making this happen. So I wanted to bring it to your attention so you knew about that. And also we did meet our goals of reducing our review time to 45 days, and then we reduced our pending, and we continue to reduce our pending, and will continue to reduce it once we have the abandonment of application regulation in place. And that concludes that report.
Thank you. I want to echo Dr. Gitnick's remarks, not only with Mr. Shunke and his ability to impact the program of getting licensing done at the front end, but the on-the-job every single day, 6 and sometimes 7 days a week of the staff coming together and working. You know, I sometimes money is the answer, but I don't think in this situation it really was only money was the answer. But it was a unified team approach from the top on down, from Ms. Whitney spending weekends here as well. And we should all be aware of that. That I think that the culture of this staff has changed, and it's changed for the positive and under your leadership, and I want you to make sure that the licensing is, and that whole division and understands that we're more than appreciative for the effort, and we don't expect to ever see it change to go back, though. Okay. So we want it to continue to do better. So I'm going to ask now for Ms. Taylor to come forward and make her presentation. Oh, we didn't do licensing. I'm so sorry. I thought that you, I apologize. Not yet. Ms. Whitney, licensing, please.
This time there isn't a full narrative report in your packet regarding the licensing report. I ran out of time, and I apologize for that. So I'm going to give a quick verbal report as we move along. In your packet, on page 169, you have the workload data for the end of the fiscal year. And this data would not have been made possible, the data through page 172, without the unique assistance of our information technology branch and Natalie Lowe, who has been tremendous in her assistance with ensuring that we have all of these reports done in a timely manner. Some of these reports are weekly. Natalie, get to stand up. Thank you. Natalie has done a superb job. And again, she came from the ISB section, ensuring that licensing got what it needed so we could all get everything done. She has since moved on, and I'll let Renee talk about that later on. If you'll turn to page 171, that report has now been updated, and we handed out our new information. And again, it shows our weekly production. What I would like to see in the future is a breakdown between the U.S. Canadian and the IMG in terms of initial review pending. And the reason for that is because we understand that U.S. Canadian applications are easier to process in terms of getting their materials here faster, but the international grads tend to have materials coming from out of country, and because of that, their applications take a little more time to be complete. Thus, I want to break that down so you can see that, and we can then follow the trends, because we're not sure that 45 days for the initial review is really the right number of days, because everybody has to get a letter of deficiency. So we will be examining that, but at this point in time, we're still keeping our 45-day commitment that we're trying to achieve. We did go up a little bit on the July 24th report, but we're really excited getting our pending review mail down, and hopefully in the very near future, it will be all within a week and maybe some of it within the same day. And that concludes my licensing report. Any questions?
No, thank you very much. You all should know that this is reviewed every week. Every week they're hammered on questions. Their feet are held to the fire, and really thank you, Ms. Whitney, for making this happen. Okay, so moving on to number 19, the Special Faculty Permit Review Committee report.
Good morning. Please refer to your board packet, tab 19, page 173. As required by Section 2168.1C of the Business and Professions Code, the board has established a review committee to make recommendations to the board regarding applicants for a special faculty permit. This committee includes one representative from each of the medical schools in California. The Keck School of Medicine at the University of Southern California has nominated Dr. Frank R. Sinatra as their new representative for the Special Faculty Permit Review Committee. Staff recommends approval of Dr. Sinatra's appointment to represent USC on the Special Faculty Permit Review Committee. And I'm happy to answer any questions you may have.
Does anyone have any questions? Taylor? Do you want to give a minute on what is a special faculty permit?
Anita?
What do they do? Who participates?
A special classification of, well, let's see, it goes back to Dr. Friedman's idea that the UCs and the other medical schools in California needed to be able to recruit the best people in the world. Some of those people may not qualify for licensure in California. They needed to be eminent in their fields. And so as a result of his efforts, a law was passed that created a special faculty permit, which is a permit that allows, or a license that allows a physician to practice at a medical school without going, it's a different kind of a license, only at the medical school. So it's a restriction on location and practice. That person can renew their permit just like a physician who has a regular license can. It was designed, as I said, to provide for the needs of the schools in recruiting the most eminent people in their fields. At some point after this permit was authorized, the board decided it needed to have some special expertise in reviewing the applicants for this permit. I believe there are only 16 people thereabouts who hold a special faculty permit. So in law, there is created a committee that consists of 2 members of the board and a representative from each of the 8 California medical schools. Those individuals evaluate the qualifications. The person whose applicant is from their school does not get to participate with respect to their own school. They leave the room, get off the telephone call if it's a teleconference meeting. So this USC, right? Mm-hmm. USC currently has, and it's specified, I believe it's at a dean level or higher. So there are some limitations on who can qualify. They're set out in the regulations. So this would be a replacement for the current person at USC. The schools nominate their own folks. We don't nominate them. The board decides who it's going to put as the 2 board members on the committee. But it's up to the schools to select as long as they meet the criteria and the regulations. And typically the board approves them.
Okay, so thank you very much for that explanation. I'd like a motion to approve this nomination. So moved. Second?
Second.
Okay, any public comment on the appointment? Any comments from the board members? All those in favor of the motion? Aye. Any opposed? Any abstentions? Okay, so done. So now we're going to move to number 21 on the Ms. Scurry and Ms. Thompson on the approval of the Bastyr University Midwifery Program.
Good morning, board members. I'm Cheryl Thompson with the Licensing Operations Analyst for the Midwifery Program. In 1994, the Seattle School of Midwifery was approved by the board as a 3-year midwifery education program, meeting all the qualifications required by the Business and Professions Code and Title 16 of the California Code of Regulations. On March 23rd of 2010, the Seattle School of Midwifery merged with Bastyr University. The program, which is now known as the Bastyr University Department of Midwifery Program, is identical to the one that was offered by SMS and that has been previously approved by the board. The Seattle School of Midwifery has been accredited by the Midwifery Accreditation Council, we call that MEAC, since 1996. And when the change of ownership was approved by the MEAC, MIC accreditation was conveyed to the new Department of Midwifery at Bastyr University. The Bastyr program remains in good standing and is fully accredited while the reaccreditation review is in process. So medical board staff recommends that the board grant recognition to the Bastyr University Department of Midwifery program with retroactivity to June 2010 when the first class graduated from Bastyr instead of SMS.
Thank you. Is there a motion to approve this program? Second?
Second.
Is there any public comment on this item? Mr. Cuny, you know the rules. Wait, okay, you can come forward. I'm going to put you down for this one. Oh, you're here. I apologize. Number 21. Sorry, you're fine.
Frank Cooney, California Citizens for Health Freedom. I urge support of this motion. Thank you.
Thank you. Any other public comments? Any comments from any board members? All those in favor of the motion as stated, please say aye.
Aye.
Any opposed? Any abstentions? Okay, thank you very much. So done. Thank you. So now it's 11:40. We're going to take a lunch break for 20 minutes max, and we're going to come. Well, don't you know? We're going to come back, and we'll be starting at 12 o'clock. It is what it is.
Just tough loss.
You want to be here today? Or you want to be here tomorrow?
I want to be here today.
You want to be here today? Going to him later and talk to him. Okay, I'd like to call the meeting back to order, please. I'm going to move on the agenda to item number 15. Assembly Bill 329, carried by Assemblymember Nakanishi in 2007, authorized the medical board to establish a pilot program to expand the practice of telemedicine in California. The purpose of the pilot is to develop methods using telemedicine to deliver health care to persons with chronic diseases. The pilot also shall develop information on the best practices for chronic disease management services and techniques and other health care information as deemed appropriate. The bill required the board to report to the legislature with findings and recommendations within 1 calendar year after the commencement date of the pilot. In your board packets, under tab number 15, you have the first annual report presented to the legislature earlier this month. The 2 subsequent annual reports will evaluate the effectiveness of the pilot. The final report, summer 2012, will include a summary of the pilot and evidence-based recommendations. I would like to introduce Dr. Jim Nuovo from UC Davis, the principal investigator of the team guiding this project. Dr. Nuovo, who can introduce the other members of this project's team, is here to present a summary of the pilot's milestones and accomplishments during the first year. Assembly Bill 329 carried... I just read that. Sorry. Please.
Okay. Oh, all right.
Start. I have 2 copies of what I don't think you want me to read it again.
Okay.
So thank you for coming, and thank you for being here, and see what you have to say.
All righty. Well, first of all, thank you to all the members of the board for inviting my team to come and give this presentation on the first annual report on our efforts on AB 329. This represents an effort, a combined effort of the board, our chronic disease management program at UC Davis, the Center for Health and Technology, who has all the telemedicine expertise, and the Center for Healthcare Policy and Research, which has been helping participate in trying to look at the impact of this intervention. We have each of our team members will come up in sequence to give you the sense of what it's like to implement such a project, some of the challenges, some of the barriers. The overall goal, we have 10 years of experience in the UC Davis health system and have the challenge of taking care of 16,000 patients in our health system with type 2 diabetes, a disease which is an epidemic, and the challenge, of course, being all the complications that occur from this disease. In our experience over all these years, one of the most important lessons learned is the critical role of self-management support and education as an effective strategy to helping improve outcomes that tend to be worse in underrepresented groups and especially people in rural areas. That's really the soul and the core of this particular intervention. What we have learned is that the intervention of education and health coaches, if you've not met health coaches, we have two superb examples of health coaches, has been shown in our studies to be as effective or more effective than any medication. That's something to keep in mind here because it shows the power of education and the power of self-management support in these types of interventions. So I'll turn this next to Glee Van Loon. She'll introduce herself and describe some of the recruitment issues that have come up in this project.
Thank you. Hi. Nice to meet all of you. My name is Glee Van Loon, and I'm the project manager, which means I take care of a lot of the day in, day out activities happening around this project. What I spend a great deal of my time doing is site recruitment. And that means taking the 18 sites that our goal is, 18 rural sites throughout California, and trying to recruit them into this project. So some of our recruitment has stemmed from a few different avenues. Up to this date, our recruitment, I should back up for a moment, our recruitment actually got well underway and quite a bit of momentum behind it in March of this year. It took us that previous amount of time to get the project ramped up and ready to roll. So from March forward, we've been fairly aggressive in our strategies to recruit rural sites. I've contacted 39 sites to date, and some of our recruitment techniques have been, first and foremost, collaborating with our telemedicine department and all of the contacts that we have established with our telemedicine folks that are already participating in one method or another. So we send out emails to a lot of those folks as our initial contact, and I follow that up with phone calls and letters and emails, whatever form of communication I can really connect with folks at those sites. Additionally, we've reached out to our Rural Prime contacts with Dr. Hilty and are using some of the connections that we have there in those rural areas to, because they're prime for this type of project, to really establish some inroads with the Rural Prime communities there. Another area that's been extremely fruitful for us has been working with consortiums and associations. The Health Alliance of Northern California consortium has been really very, very instrumental. My contact there was wonderful and took a lot of this and ran with it and presented to her network, which is 9 counties in Northern California. And that association has been very, very fruitful for obtaining some sites that are really quite interested in this. So to date, we have brought up 3 sites. Three rural sites are up on board. Yesterday, we brought up our 3rd one. And it's very interesting because some of the barriers that we're running across are quite interesting and not necessarily what we would have predicted. We're running across some interesting things such as staffing issues. I have a site I talked to, and their doctor had just left. It was the only doctor at the clinic, and they're having trouble replacing him. So clearly I can't work with a site that doesn't have a doctor there. Subsequently, staffing issues. I have a couple of sites that are ready to come on board with this project, and we have to have a site champion or a person at the site that can really lead this project on site, because we're a lot of support here, but on site you have to have somebody leading it. Well, in the site champions, one of them quit unexpectedly and left the practice. Another of them went on to an extensive medical leave, and there's nobody else at these sites that can pick this up and go. So it's interesting, the sites have some staffing issues that can get in the way of running a project like this. Sometimes it's telemedicine equipment. Sometimes they don't have connectivity. I have a T1 line that went down at one rural site, and they can't get it reconnected because they're so rural. So, some of the barriers in recruitment are things we wouldn't have anticipated. But we have a lot of interest out there, a lot of, overall, I would say this project is being well received, and it's a matter of getting through some of the barriers and really helping these sites be successful by doing what we can do. Our team is quite supportive, so as long as they have someone there that can run with it, it can be a go. I think that moving forward, we're going to be doing some work in the Central Valley and expanding our scope out a little bit more into the southern Central Valley, I should say. So certainly going forward, we're looking for all the opportunities we can find. Lots of folks in this room have a lot of people that they know out in their areas. Certainly, if there's anybody you think that could be benefiting in your communities from this, we welcome that. And I have my business cards here today, so feel free to let me know if you have anybody out there that might be a great connection with this. So I thank you. We'll continue to recruit and move forward, getting those 18 sites.
Thank you very much.
And so next we're going to have Tom Balsbaugh speak, and he's going to talk about some of the teaching opportunities in this.
Hi there. Thank you for having us today. My name is Tom Balsbaugh, and I'm the consultant for the Project for Provider Education. I'm a member of our Chronic Disease Management Group and the residency director for the Family Medicine Residency at UC Davis. I have a lot of experience in a number of projects with both chronic disease management and UC Davis's effort to roll out medical homes. I'm doing this part of the project because I have a strong interest in both diabetes and quality improvement for diabetes. What we do in terms of the provider education, we have a few principles. One is to promote and educate about the chronic care model. The chronic care model is a model of care that was designed to be team-oriented, evidence-based, that used population management as a principle, and that really emphasized self-management support. It's all wrapped within the other idea of continuous quality improvement. And those are the foundations of our efforts in education with each practice. We're also trying to respect the expertise of each physician and their team that they bring and their unique knowledge about their community and their own practices, and to engage in a collaborative approach to learning. We also hope to incorporate the latest evidence within each practice as it relates to primary care. We've planned 60-minute telemedicine discussions during lunches at the practices, and some practices will actually can be online together, and that we hope to be able to share information between practices. Providers are queried ahead of time to determine which topics they're interested in discussing, including diabetes self-management tools, initiating insulin, choice of oral diabetes medications, practice redesign for improved chronic disease care, and finally managing cardiovascular disease and diabetes. We're hoping that one of our goals would be that each practice could learn and spread some of the things they have from their practice and what we exchange together with other practices. And we're also providing them CME credit for the time that they spend on the discussions over lunch.
Thank you. And?
Okay, I'm Bridget Levitch. I'm the Director of Chronic Disease Management at UC Davis. And in this project, I'm the educational advisor for the health coaches and a mentor for the coaches as they move forward, both teaching and in a little while coaching the patients. So as you know, chronic disease management is largely managed by the person with the chronic illness. And although the provider, physician, plays a large role in terms of decision making and empowering patients and making perhaps medical and pharmacological decisions, the patient goes home day in and day out and self-manages, whether they do that optimally or not quite as optimally, it certainly is up to the patient. So what we've done or have the opportunity to do within this project is to really work with the patients through a televideo classes to empower them and enrich both their education and their ability to step up and take charge of their own condition. The biggest thing that we did up front was to design our book, which Jennifer and Gisela will show you in a moment. But what I wanted to clarify and be really specific about is that since this is a one-time 2-hour class that these patients have the opportunity in which to engage with their chronic illness, it's very much one of working with the patients around their own behaviors and behavior change and action plans. Rather than spending a lot of time on the medications or even lab data for that matter. It's mostly giving the patient some basic information about what we know makes a difference with acting as a person with diabetes to self-manage. I'm going to go ahead and turn it over to Gisela Escolara and Jennifer Fernandez, our coaches, and we really are excited for them to be able to show you the book and tell you about their role.
Thank you very much.
Hello. So we are the coaches. My name is Gisela. I'm Jennifer Fernandez. And we're the faces that people get to see when they join our classes. We also provide a lot of the support to the site coordinators and to the sites once they come on board. And we help them develop tools to help recruit their patients. That poster there is an example of one of the flyers that we've designed to help recruit patients. And that was in Spanish, and it really speaks to the family and the importance of family in the Latino community. And so it asks do people want to maintain themselves healthy for the well-being of their entire family.
Our classes are co-taught. We consider that to be one of the strengths of these classes. We also try to take into account the different styles of learning that patients have. So some people are more traditional, they prefer to take notes, and others like to be more interactive, so we try to accommodate a range of those styles. Personally, as health coaches, our goal for these classes is for these patients who so often come to us totally overwhelmed to leave feeling like they understand what they need to do to manage their diabetes and they're confident that they can do it. So we're hoping for those click moments to happen during the class.
And we've brought copies of our booklet that we've placed along the way there. And
Right there on the ledge.
Yeah. So every one of the participants who attends our classes gets a copy of this booklet, and we're very proud of it. So we wanted to go over a couple of pages.
Mm-hmm. So on page 10, you'll see good news about diabetes. We like this page because I think it really encapsulates the way that we try to take a positive approach, preventive approach, and we try to break diabetes management down into steps that are manageable for patients. I like the fact that we discuss stress here. A lot of people don't consider stress something that will affect their diabetes health, and it does. We like to share with patients an anecdote about a man that we once observed in a monitoring group who started a nightly ritual of drinking chamomile tea and discovered over the course of several days and weeks as he was monitoring his blood sugar that this had a huge effect on his numbers.
Mm-hmm. And the next page we want to you to look at is page 13, which is our Nutrition 101 page. And this is our favorite page. We think it's the most informative page in our booklet. It really helps us to do a lot of myth busting around food.
So some of the myths that we currently encounter are that carbohydrates are bad for you. You can't have any carbohydrates at all. Patients are always pleased to learn that they can, in fact, eat carbohydrates and even dessert. Another myth is that you can't have carrots or tomatoes because those foods have natural sweetness. Another myth is that fat is bad for you. We had a gentleman at a class just on Wednesday who waited until the very end and sort of steeled himself and said, all right, so now you can deliver to me the bad news about peanuts. And we told him that there's, in fact, a lot of good news about peanuts and that although they're higher in calories and you'd want to eat them in moderation if you're having weight management as a goal, they're also a great source of nutrition, and they're heart-healthy fat. You'll see that we have heart-healthy fats highlighted in red. We like to use color throughout the booklet to facilitate learning.
And the next page is the next page over, which is page 14. And we feel that this is one of the favorite pages for participants. They really like this page because it's not complicated. There are no numbers involved, and it uses tools that they already are familiar with. And
Exactly. There's no need to run out and buy a scale or a calculator. We had a patient, and he had his spouse along with him as a support person, and they shared that just with portion control alone, using that method, he had lost 43 pounds.
And Jennifer and I like to think that that's really special about our classes. We allow people the time to share their successes and encourage others and show them that it is possible to make these changes on their own.
Mm-hmm. The last page that we'd like to ask you to take a look at is My Experiments, and I believe that is page 25. This one is the most connected to our health coaching. The idea behind this is that patients set small goals for themselves, and they choose what they want to work on, whatever it is that they feel ready to take on at that time. And an example of how this can connect to the larger support system that patients have is at Sierra Family Clinic, there are 2 behavioral health specialists on staff, and their idea is that patients will take this page to their behavioral health specialist after they've been through our class and continue to work on the goals that patients set up for themselves in the class.
And normally Jennifer and I role play this page just because we've learned that it's very personal for participants to share, their goals, and so that's how we go through it and ask people to share if they'd like to.
Mm-hmm. And the goals can be very small. Gisela?
There was one class where a woman, at the end of the class, her goal was just to find out the amount of carbs in her favorite iced coffee drink. So that was her goal for her.
And we celebrate those goals, whatever size they are.
And we've received great feedback, really positive feedback from participants about the class. They know from the start that it's a one-time opportunity because it's part of a study, and we often are asked when they can attend another class.
Inevitably, they'll say at the end of class, when is the next one, or when will we see you again? And one woman said that the class for her was like a gift. So what we tell patients is hopefully if the study is successful, there will be other classes like this in the future offered to you and to other people like you in rural areas. So that's what we would like you to know.
Thank you very much. I'd like to ask if there are any questions from the members of the board, and I don't know how we're going to put 8 people at the table, but we'll figure it out. So, Dr. Gitnick?
Well, I guess this is addressed to all of you. First of all, what you're doing is admirable, but I would like you to humor me because I think there's a possibility for a natural partnership that could evolve. So let's talk about indigent health care. Now, out of this board developed a program which is now managed through the state called the Health Professions Education Foundation. This organization provides educational loan repayment in exchange to doctors, nurses, and physician assistants and others in exchange for an agreement that they provide care for free to indigent patients for a 3-year period. And so the HPEF places these personnel in 36 indigent care clinics up and down the state. Now, if one assumes that each year HPEF is funding 50 new doctors and additional nurses, etc., and each doctor assumes the care of 2,000 lives, that means 50,000 new lives coming into the program every year, all being indigents and all organized through clinics up and down the state. It would seem to me that what you have to offer is a natural relationship whereby they could be in contact with one another and with you, and something really good could come of it for the benefit of people who have little access to care in our state. So what I would suggest you do is that we find a way for you to contact either Lupe Alonso Diaz, who is the executive officer of the Health Professions Education Foundation, or Diana Bonta, who is an executive with Kaiser, but who chairs our programs committee. You could even talk to Barbara Yaroslavsky, who chairs our development committee. But I would urge you to develop some conversation with those people to see if there isn't a win-win relationship that could evolve.
We very much appreciate that. That's one of our goals for this particular meeting, is to establish more connections, and what you're describing is exactly consistent with what we want to do, and GLEE will be working on that immediately.
Thank you. Dr. Levine?
I had two questions. One, you've got 18 sites. What's the range of diabetics in each of the sites? Do you know? Just the range across all of them?
When you say range, are you talking numbers?
Yeah. Yes.
Well, we have one site, and again, I haven't brought the site up on the project yet that I'm talking with, that has less than 100. They have around 75. And then I have another site that we'll be bringing up that has well over 300. So it really ranges quite a lot.
And how many people does the 2-hour class accommodate?
It depends on the room size that the telemedicine equipment resides in at each site, which has been interesting to learn about as well. Some rooms hold 4 people or 2 people, and other rooms, I have a site that I'm bringing up that's an Indian health site that has 20 people that fit in that room. So the class can accommodate, ideally, we like to have as many as 8 to 12 people, but it is dictated by the facility.
Can you tell me what metrics you're going to use to evaluate the impact of the intervention?
We have many metrics. Of course, one of the most important goals is, does this make a difference? And that's why we're using our research arm in our center to help us gather the information necessary. So we do have data gathering for all patients who participate, with the basic demographic and lab tests that would be necessary to follow for somebody with diabetes. We also have surveys that are more qualitative, to look at personal impacts about the meaning of these types of interventions. So we have a robust method using all the resources that we have at the university to answer that question to the board, to the legislature. Does this make a difference? What are the lessons learned? Was this an effective intervention or not? And then I guess one of the things we were trying to do is to allow the board to get a sense of some of the challenges that come up. A bolt of lightning hit one of our sites and put them down for several days. Those things happen. Sometimes the telemedicine connection doesn't allow you to even see very well the people on the other side of the screen. That can be a problem. So we're getting lots of lessons learned, some quantitative definitely, some qualitative.
And the tail on the evaluation, over what period of time?
This is a 3-year project, so we will have that much time. Our goal is to try to engage as many patients as we possibly can. Our initial target was 1,000. We'll see if we can get there.
Thanks. Any other questions? Ms. Chang?
I know it's a 3-year project and you're focused on diabetics now. Is there plans for other type of disease or in the future?
That would be nice. I appreciate that question. We have a lot of experience within our own health system on exactly that. What we've found is that when you're doing an initial intervention, it's wise to pick one condition. While ultimately since so many patients have many comorbid chronic conditions, that would probably be the ultimate goal. But diabetes is an epidemic. It is so common. It's one that is amenable to behavioral interventions, and it's one in which many physicians feel frustrated about effective interventions, and one in which many patients and their families are touched by the complications of it. So we went after diabetes, number one, because we have a lot of experience with it, and two, it's the most practical way to do an intervention. I don't think we would be able to give the board or legislature very useful lessons learned if we hit a number of different chronic conditions.
Okay. Thank you. Dr. Lowe?
Yes. So as a funded project, I can understand how this can all be done, but we improve with telemedicine access for sure. We improve quality, we believe, because we give them expert consultants that they might not have access to. We have an education piece. But in terms of real-life costs, the doctor on one end bills, the doctor on the other end bills, so we're having two doctor bills instead of one doctor bill. And then we have all the technology to support. And so is this truly a cost-effective modality that would work without third-party funding?
It's hard to say. It's very challenging the way the current healthcare system works. It is not supportive of these types of initiatives and would need to be part of a healthcare reform package as to how these types of interventions are sustainable. But that's a terrific question. We will be looking at costs as one of our outcomes to measure, but it's very challenging, and I appreciate you bringing it up as a point, but I don't have a perfect answer for
the
it now.
education piece, regular webcasting can do similar things without having to set up a telemedicine network. I mean, is this something that can be sustained by private industry? Can private industry set up telemedicine to make it cost-effective and self-supporting?
It's something I think we need to reflect on after our experience, and I'm not quite sure how to answer that right now.
I think that would be a question for the end of the report versus now, but it's an interesting dilemma. Dr. Moran?
I'm good.
No? Dr. Levine, you want to close this?
Yeah. I think, Reggie, you bring up a really important issue, and there's the Center for Connected Health in Sacramento, which is based in Sacramento, is doing some work on what they're calling a model statute for telehealth, which is looking at the existing. California was a pioneer in passing, I think in 1996, of a Telemedicine Act, and the issues of reimbursement and scope of telemedicine. I think this is a wonderful example of of coaching, using telemedicine for coaching. Where the real savings might come in is in other applications of a telemedicine model in terms of actually care delivery, not to replace doctor office visits or face-to-face visits, but to augment and amplify and support, particularly in the areas of chronic condition management. And their intent is to come out with a statute that would update the Telemedicine Act, address issues like payer reimbursement for telemedicine services, which could certainly include coaching and education, and also to look at the other potential obstacles that currently exist for more rapid deployment of the modality.
I really appreciate that point. I mean, even within our own health system, our disease management activities have the same funding problems and require leadership of the health system to be supportive that we're not getting reimbursement for these teaching and coaching activities.
Okay, is there any public comment, any public questions?
Thank you for the nice work.
Thank you for this information. It's much appreciated, and we wish you the best. But let me ask you to stay at the table, and thank you very much, because we're going to now go on to agenda item number 22. So, Dr. Lowe, would you like to
22?
Present number 22, please?
Absolutely. So 22 is an update on the Special Task Force on International Medical School Recognition. I wanted to remind everybody that the task force did produce this document in January 2010, which is their report. And much of what has gone on in licensing with applicants for medical licenses has gone on with these international medical schools. And so this task force was formed, and it's been, I think, highly efficient and productive in terms of improving timelines. So if you look under tab 22, what you see is that there are 6 schools that have submitted applications for recognition by the board, and attached you'll see the status of each of those applications. We had a shortage of medical consultants, but with a great effort to recruit more, we now have 4 medical consultants, one of whom is sitting at the table there. He's considered our experienced consultant, and we also have brought on 2 additional consultants. So if you look at the timeline, you can see that we're quite current in terms of where we are with each application. And Dr. Nuovo is here to discuss the application from the American University of Antigua.
Okay. Thank you, Dr. Lowe. Well, again, I'm Jim Nuovo. I'm a professor, and I'm the Associate Dean of Graduate Medical Education and Student Affairs at UC Davis. I've been at UC Davis for almost 19 years now. And what I will be doing is presenting my summary, which you have in your packet, of the assessment of the application from the American University of Antigua College of Medicine, with the goal being to determine if the medical education received at the school meets the requirements of the current California statutes and regulations for recognition by the medical board. Well, given my presentation, and I understand this type of presentation could take a very long time, I will try to give you the highlights in terms of the process of review, the key themes in the report, and then I have some comments regarding the July 20th letter that was sent from Neil Simon to the board and address some of those concerns that came forward. The process of review was that, again, as a consultant, I reviewed the elements of 2089, 2089.5, and 1314.1, and I am familiar in my role as an Associate Dean of Graduate Medical Education and Student Affairs of accreditation standards for schools of medicine. I participated in many accreditation reviews over my years, and I am not recommending that the AUA school be held to any higher standard than other international schools or LCME accredited schools. The process of my review was that the AUA school should receive the same standards applied to other schools of similar structure. The overall assessment on page 1 in my recommendation was that in order to determine whether the school is in substantial compliance with the aforementioned statutes and regulations, I recommended that the board consider a site visit of the school. I have a minor modification of that which I will explain at the end as I'm discussing the July 20th letter. A site inspection of the campus and a representative sample of clinical sites will permit a review of records, a discussion of issues with school, hospital administrators, faculty, and students to assess the structure and content. This will allow a site team to assess the issues brought forth in the review, some of those, not all, but some of those being issues about patient census data, the volume and nature of the experience for students, the impact of other trainees at the sites that the students are at for clinical training. And again, the overall theme is, my belief is that a site visit is the next logical step in the assessment of the program. On page 3, regarding B&P Code Section 2089, in my statement that I made on this report, there is one change that I'll make based on the July 20th letter that Mr. Simon presented to the board. It was unclear to me at the time whether the school met the requirement of having specific curriculum in pain management and end-of-life care. in the July 20th report presented by Mr. Simon, he gave evidence that would indicate that the school does indeed have curriculum on pain management and end-of-life care. So again, the theme here is that this was a preliminary report and not meant to draw substantive conclusions about a final assessment of the school. Regarding BNP Code 2089.5, when I was reviewing all the data from the school, there were certain areas, and again I'll highlight these as certain areas, not to mean exclusive areas that were of concern, but 2089.5 E number 2 came up as an issue, and I'll just read it briefly. The description shall, the school and hospital shall provide to the board a description of the clinical program. The description shall be in sufficient detail to enable the board to determine whether or not the program provides students an adequate medical education. There's also on that E number 6, the school shall supervise the implementation of the program on a regular basis, documenting the level and extent of its supervision. And number 8, the hospital shall ensure a minimum daily census adequate to meet the instructional needs of the number of students enrolled in each course area of clinical instruction, but not less than 15 patients in each course area of clinical instruction. These are the key themes that emerged in my review of the data that was presented to me by the board and led to a series of questions as to whether the school could provide the evidence necessary to determine whether the school met these particular requirements. There are some changes on page 3 based on the July 20th letter, and on the previous information I had was that there were 40 hospitals for clinical training. This was amended by Mr. Simon in his report to indicate that there are 17 clinical sites for training. But what I was looking for is more specifically is to whether the school had elements such as, and again this is not all inclusive, such as clinical experience logbooks, a method of looking at the variability of training between these 17 different sites, and to ensure that there was a method of competency-based performance assessment. Those were the key features that I was looking for, and the reason that I used the language that I did here in the report was simply to say I didn't have enough information yet to make that determination, and my belief being that a site visit would be the natural step, the logical step to make that determination. On page 4, the section 1314.1, one point I do want to make, that this is a review that had started in 2008, and section 1314.1 was amended in January of 2010. I believe I can't remember the exact date. So there was a change in the time frame that occurred here. But there are features of 1314.1, and again I'm not making this an all-inclusive statement that these were the only concerns that I felt that the board needed to pay particular attention to. One of those is B number 3, curriculum, being the objectives of the education program shall state in outcome-based terms what students are expected to learn. When an institution provides clinical clerkships at multiple teaching sites, the institutions shall demonstrate comparability of educational experience for all students across instructional sites. That was one theme that emerged in my assessment of the school's ability to meet 1314.1. Another is number 4, clinical oversight. The system shall ensure the faculty monitor and verify student experience and modify it as necessary to ensure the objectives of the clinical education program will be met. Finally, number 14, evaluation of program effectiveness. An institution shall collect and use a variety of outcome data to demonstrate the extent to which it is meeting the educational program objectives. Outcome data means specific, measurable outcome-based performance measures of knowledge, skills, attitudes, and values. For example, measures of academic progress, completion rate, performance of graduates in residency training and licensing and certification examinations. These were the key themes that emerged, and what I was looking for from the information that I reviewed from the school was information to demonstrate that there's analogous to a quality improvement initiative in which there's a close-the-loop activity in which committees meet and review performance reports in aggregate and individual on all the core competencies that one would expect a student to achieve, and that there's evidence of modification down the road, because all schools would be doing that as a normal process to look at their data and determine if a modification needs to be made. Regarding my final points on my presentation, sorry if I'm taking too much time on this, but I do have to go through these step by step. The final points regard the July 20th reply, of which I had the opportunity to review. I want to emphasize to the board that the report that I prepared that's in your packet should be considered preliminary. I did that because I understood that there was an urgent need to include this on the agenda for this meeting and wanted to make sure that you had a sense of what my assessment has been during this time. I didn't include the materials that came on July 20th. Well, first of all, my report was July 13th. The packet is July 20th. So if there's any sense that I purposely excluded this information, it's unintentional. It's not what I meant whatsoever. One of the concerns that came up in Mr. Simon's report is how I use the terms unclear and insufficient. And my intention was to convey a belief that a site inspection is the next logical step. But I cannot make a determination of adherence to these rules and statutes and so forth based on just the information provided, and some information I felt was still missing. We did have a conference call on June 22nd. Actually, Mr. Simon came in person to that meeting, and we asked for very specific information that honestly reflected many of the points that I just made. I hadn't received any information, although coming to the board today, there's a large binder in my box that looks just like the binders that have appeared before me. I have not looked at it. I'm assuming it is likely to be the response to the teleconference call that we had on June 22nd. I don't know. I'm just guessing. That may modify my recommendations to the committee in determining it may be wise to have the opportunity to review those documents before, but I'll leave that to the board to make the determination, because I honestly have not looked at the packet other than seeing that it's in my box. I do want to address some of the other comments that Mr. Simon made in his letter. One of the a theme that emerged was he felt that there were inconsistencies or inaccuracies. One was about the 6-year program for associate science degree and so forth. Actually, I believe there's value in putting that in the report. Of course, we had a 2-year time frame here, and things change over time. If the board eventually moves to approval of the school, there will have to be a determination of retroactivity in terms of which students are approved or not, and knowing that there were different programs may have a bearing on that particular decision. So that was the reason in the report. It was not intended to be misleading as to what were the different features of the school, just to say this is what was presented to me originally. It has changed over time, and this will eventually come up as an issue should there have to be a determination down the road. And on the bottom of page 5 of Mr. Simon's report, he characterized my statements as conclusory and factually erroneous regarding whether the clinical program provides students with adequate medical education. The reality is, again, I want to reflect on the language that I was using. I'm not making conclusions yet. I'm saying that there still needs to be more information provided, perhaps before a site visit, perhaps it's sitting in my box right now waiting for me to sit and review, or to also be obtained through a site visit from a team. Just a few more points and I'll be finished. Bear with me. One of the comments that Mr. Simon had in the report was that feeling that a site visit wasn't necessary, that passing step 2, the clinical knowledge and clinical skills, was in itself sufficient information to demonstrate that students had achieved the clinical competence necessary to move to the next level. I disagree with that. Step 2, clinical knowledge and clinical skills are important elements to review, but they don't supersede the other issues I already brought forward in terms of looking at objective, competency-based assessments that are done by students on clerkships and reviewed by the institution and assessed on a basis to determine if modifications in curriculum need to occur. And the site visit, of course, will give opportunities to evaluate more specific information, including census, impact of other students from other institutions on training, and so forth. In my report, I also reflect on the impact of KMCIC, the Kasturba Medical College International Center. Honestly, I was confused. I wasn't sure if this was a branch campus or not. And we did have Mr. Simon discuss this issue on our June 22nd meeting. I still was confused as to whether it was a branch campus or not. However, my take on the July 20th, and it's my take on this, I might not be entirely correct. It appears that what we'll be doing is that those students from KMCIC who get clinical training through AUA-COM will not be considered eligible towards satisfying the requirements for licensure for the board. If that's indeed accurate, that simplifies and modifies my interpretation that I presented to you in my preliminary report. Let's see, anything else? I think finally, again, I think there was a point that somehow I was reflecting a higher standard that was applied to the school. And again, I want to emphasize, as someone who's been in LCME site visits, someone who's been in ACGME site visits, someone who has done work for the medical board and reviewed other international schools, that I'm using 2089, 2089.5, and 1314.1, again, which was modified. So I could appreciate a perspective of why am I being held to the same standards? Well, 1314.1 was modified during the time of the assessment. So again, I apologize for taking as much time as I did on this, but just trying to hit the key themes. I want to be sure that you understand that I'm hitting key themes and not going into each detail here, because I think that's more of an effective strategy to present a complex situation such as an assessment of a school.
I want to thank Dr. Nuovo for his hard work and very thorough assessment of this school. I think this reflects the seriousness that the board takes in terms of looking at all all new applicants. And again, I want to emphasize that we applied the current standards for all schools, and it's uniform, and that there's nothing unique about it. I think that what we should do now is to make a motion that we direct the staff to set up a site visit if it's deemed necessary after your review of the additional materials that have been sent in, so that we can move forward with their application. So
is that a motion?
that's a motion.
Second. Okay, so now we'll have some discussion on the motion. Okay, and from this body first and then otherwise. Okay, so is there questions from members of the medical board on what you've heard today from Dr. Novo? So is there any public? I have public comment, so why don't you just stay there since we're not finished yet. I have public comment from people, and I'm going to remind you that the same rules apply for those that have come in late. They might not be as aware of that there's a 3-minute limit on time. You've got to stay on subject, please. And it's not for a conversation. You're being afforded the opportunity to speak to us for 3 minutes. So I'm going to call on these people, and I apologize if I've mispronounced any names. Leonard Schlafani. I apologize. Good morning. Please come, please.
By this time.
It's afternoon already, but it's okay.
My name is Leonard Sclafani. I am Vice President and General Counsel of American University, and I'm here to, on behalf of American University's application for approval by the California Medical Board. Mr. Simon was intending to be here today to make this presentation, but he was on an airplane runway for 4 hours yesterday, and when the plane finally took off, it turned back for engine problems. He then stayed at the hotel at the airport with the idea that he'd fly here this morning, and that flight never arrived. So I happen to be in California on an unrelated matter, and I agreed to at least introduce those who I think can best address any questions that the board may have. Dr. Jagbir Nagra is AUA's Executive Dean, and Dr. Peter Bell, who's with us, is AUA's Clinical Dean, Executive Clinical Dean. And I would suggest that if the medical board has any questions, that they would be the appropriate people, as your issues, I'm sure, are more academic, and I am certainly not an academic, so I stay away from anything in that field and leave it to those who are professionals there. I do feel that some comment is in order. We do engage in a certain amount of involvement in each other's comments back and forth, Mr. Novo's comments and I'm sure Mr. Simon's comments, and I don't want anything that Mr. Simon has said in any of the submissions to be taken as a criticism of the hard work that Mr. Novo has done, Dr. Novo has done over the course of time. I understand it's a hard and arduous task, and I do think that some address of the question of the standards by which we're held is in order, since Dr. Novo raised it. I'm not suggesting that we're held to a standard higher than the LCME, although I think in some cases that is the case. For example, the sites of clinical rotations are vastly different for foreign schools than they are for American schools. But I've seen many of the California Board's recommendations and approvals of schools in Eastern Europe where no site visits were done, no hospital integration was done, no visits to the hospitals. The Elam School in Cuba also no hospital visits, and those programs require that the English-speaking students who are going to be trained now in hospitals in Poland and in Hungary, areas where the doctors don't speak English, the records aren't in English, the patients don't speak English, and they are getting their clinical education there, and the assumption is that these students are getting comparable education. In one school that I saw, the 50% of the students do their clinical rotations in sites that the hospital has no control over, that the medical school has no control over. They have to find their own site, 50% of the clinical courses. And there were no site visits done. All of our students, all of our clerkships are in ACGME, they're in JCO hospitals, they're accredited, they're in residency, they're in hospitals that have residency programs. The California regulations that Dr. Novo cited about 15 patients census specifically exempts from the census count hospitals that are either associated with an LCME school, and in our case we have an arrangement, an agreement with San Juan Bautista Medical School in Puerto Rico, where our students go to San Juan Bautista as visiting students, and they do their rotations as visiting students of San Juan Bautista Medical School in those sites.
Take a breath, take a breath.
Right.
Just please. There's a sentence, and there's a period at the end of some sentences. I just want to remind you about the time limit.
And I'm just about done.
Please.
And so I think that, Dr. Novo said that he was concerned that there wasn't a way of doing objective standards, logbooks, and the like, but we did submit samples of the portfolios that all of our students are required to do in all of their sites, that are reviewed by clinical chairs who visit the sites on a regular basis, by the deans who visit the sites, by meetings that are had that alter the curriculum. I will make this disclosure that you should know. In January, we are proceeding to change in a rather significant way our curriculum from a 16-week per semester curriculum to a 20-week curriculum. And we will be using only a two-semester system during the course of the year, not a three-semester system during the year, to better provide for opportunity for our students to gather the same essential material but in a longer period of time, which are the types of changes that we make in the course of time in order to accommodate the comments, the feedback, the data that we get, the performance of our students, which is that which Dr. Novo says that he needs to see. In that regard,
Sir, I've got to really...
I'll cut it off right now.
Seriously.
The last statement I will make is that while we think that we have demonstrated through the material sufficient information from which this board can conclude that no site visit is necessary, we welcome this board to visit our campus, to visit our hospitals, to do what they need to do to ensure that they are fully confident. I'm sure that that visit will do nothing but shed praise and security on the mind of this board that students that come from AU Day are well equipped for the graduate medical education.
Thank you. The next speaker. Jabir Nagra, and I really need to caution you, we have other people that are here that have time constraints on their time, and everybody's time is of equal value. So I'm going to ask you please to try and keep your comments to 3 minutes, please.
Good afternoon.
Good afternoon. Something. Thank you. Sorry.
I'll take this opportunity to first reassure you I won't take my 3 minutes.
Thank you.
Secondly, I'd be privileged to play host for you. If you would like to have a site visit, I'd love to see you in Antigua. Thirdly, I would like to re-emphasize what Len was just saying, that we are moving towards a new curriculum, which is 24 months, which is going to be reinforcing our commitment to excellence. I would also like to just acknowledge and place before you the fact that this is the 4th geography that I'm working in as the Dean of a medical college. I bring to this particular appointment my experience and abilities, wherein I have in the past, whether it be in Nepal, Malaysia, or India, have helped students to perform exceedingly well in the United States, and many of them are practicing in the state of California. And I hope to be doing just that with the American University of Antigua.
Thank you very much. Thank you. Peter Bell, Dr. Peter Bell. Dr. Bell, I'm going to only ask you at the beginning, not the end, but when you're finished speaking, if you would move that chair to the side, it's driving me. I can't see the audience, you know. I apologize. It's just making me frustrating.
Good afternoon. Thank you for having me. Thank you for having us. I'm the executive clinical dean. I'm the executive clinical dean of the American University of the Antigua and the vice president of academic development. We will welcome a site team, as Len and Dr. Nakra have said before. We think that our university can contribute with our students, with our graduates, highly to healthcare in California. And a large number of our students originate from California. So I really think we can work together on solving some of the problems. Beside that, I'm here to answer any questions you might have.
Thank you. Any questions for Dr. Bell? No, okay. Thank you, Dr. Bell, for your time. I appreciate it. Just please push it aside. Thank you. So as we go forward, I'm going to suggest an amendment, Dr. Lowe, to your motion, if you would be so kind, and that is to move the site visit forward pending review of the new materials that Dr. Nuovo might have received or has received, and determination of the executive director, and allow her to move forward to proceed with the site visit.
How was that different?
I don't know. I was asked to do it, so I'm doing it.
Ms. Yaroslavsky?
Executive director, which is fine with me.
Oh, okay.
Thank you. So, and the second person, and the person whoever made the second would accept the amendment, I assume, as well. And now, yes.
For clarification.
Yes.
The motion had included some other things. So is the motion really to direct staff to set up a site visit after review of the new curriculum?
Pending that the information that Dr. Nuovo has received or will receive, or that's there, it makes it appropriate for him, has the information that he needs to make this
So after
work.
receipt of all the requested information,
Right.
and also, did you want to include, since we've found that they're making a major...
All the information.
Receipt of the information that he has and review of the information that he has.
Right. Well, we've heard from Dr. Nuovo that it's time to make this site visit. Pending his review. So I want to make sure that pending of his review that the executive director is so requested versus ordered to start the process to make this happen. Okay? If appropriate, of course. Okay, so that's the motion on the table. There's no public comment from, if there's any public comment? No, fine. So all those in favor of the motion as it stands, amended, say aye.
Aye.
Any opposed? So it's any abstention, sorry. Thank you very much. Dr. Nuovo, wait, don't go anywhere yet.
Oh.
Approve of a site.
We're going to now move forward with the approval of a site team. Okay?
Okay.
Do you want to make an official who should go from the board, or do you just want that to be worked on with the executive director and the medical consultant?
I would think that that's more appropriate.
Okay. The next one would be the hospital sites, the clinical sites. Do you want one site reviewed, or do you feel that you should leave the determination of the number but limit it to a certain number between the medical director or medical consultant and the executive
We're
director?
going to have to leave that up to the medical consultant. I want this board to understand very clearly that this person sitting in front of you is our medical expert on this. He is our representative to make our decision in the best, with the best information he has. He is the person we have empowered through his expertise to advise us.
Right.
So I just want to make sure that we all understand exactly what, apologize, Dr. Nuovo, but make sure that we all understand what your role and responsibility is here.
But for fiscal reasons, I think this board should have a sense of how many hospitals or clinical sites you are going to be suggesting that we go to for out-of-state travel. Up to or less than?
I need to see the information that's in the packet.
So we're going to have to wait on that information.
I have to review that information to make that determination.
So will this board authorize the executive director to, with the medical consultant, make that determination being fiscally responsible?
Yes.
Yes, absolutely, without problem.
Typically, the site teams have gone to the 2 or 3 locations where the greatest number of students are located.
I agree. It's most likely going to be the strategy that's used, but I don't quite know until I take a look at that information.
Thank you. And I just also want to remind the members of the board, just for a point of information, that when schools are approved that have been in the business of educating their community and their students in their country to serve in their country, there is the assumption that they are staying there. When the schools are educating students that are mainly American students that will be coming back to practice here, it's a different program. So that I just don't want to think that. And when students are being trained and educated in this country, there's also it's a different understanding of what's going on. So I didn't want you to think that we picked out the Caribbean and they're getting treated to a different set of standards than anyone else, because it's any school that fits in within the categories that they're fitting in is what they are expected to rise to that bar. Okay? Thank you very much.
That's it.
That's it? Oh. We voted on the motion. Oh, I apologize. I thought we had voted on. All the addition was, okay, I apologize. The motion on the floor, you want to review the, Anita, would you review the direction?
Just include the direction.
That's what I thought we had voted on. I'm sure we did.
You don't need a motion for the
No.
direction? Okay.
It's part of the original. Okay, thank you, Dr. Nova. We're going to move on the agenda now.
Thank you.
We're going to move to item number 20. Dr. Ruth Haskins and Ms. Gibson regarding the discussion on midwifery, barriers to midwifery care. Thank you, Dr. Haskins, for being here. Thank you for making time in your busy medical profession to make it here. So thank you.
Thank you for inviting me. We'll keep this brief. In order to keep it brief, we've actually encapsulated my comments on a piece of paper that's being handed to you. My name is Dr. Ruth Haskins. I practice obstetrics and gynecology here in Sacramento. I am one of the members of the Midwife Advisory Committee for this Medical Board of California. I'm the vice chair and have been for the last 3, maybe 4 years. In our last meeting, April 8th, this past April 8th, in the public comment section at the end of our agenda, there was considerable flurry of excitement and ideas where one person got it started and it all went rolling. And what came up was a flurry of comments about barriers to the ability of women in California to access midwifery care from the licensed midwives. And one thought after the other came rolling out before we realized we're off the agenda. We really need for the medical board to designate us to investigate this area. I will tell you that when it comes to the delivery of health care to pregnant women and their newborn babies in California, all stakeholders, the medical board, ACOG, which I'm a member of, the California Medical Association, and certainly the midwives, all of us have a vested interest in these deliveries being safe and being under the standard scope of practice, a standard that all women can expect, whether they choose to have an out-of-hospital birth or whether they choose to have a hospital birth. And so it is in all of our best interest to get rid of these barriers. What we're asking today is that the Medical Board of California allow the Midwife Advisory Committee to investigate these barriers and to come up with some possible solutions to them. Some of these barriers, just for your information, so we're not talking in a vacuum, are listed at the bottom of the page that you've now had a chance to look at. Can I answer any questions?
Do you have any questions? So you're going to, does the public have any? No. So you're going to want a motion to have the medical board authorize authorize the Midwifery Advisory Council to investigate this. Is that correct?
That's correct. We would like, within the Midwife Advisory Committee, we would like to form a task force that takes a look at each of the barriers that are listed at the bottom of that form and perhaps some others that just didn't get a chance to come up at that last meeting, and come up with some possible solutions. Some of the solutions, the members of the committee and their organizations can start the solution. Some of them we may come back to the medical board and ask for help.
Thank you. Okay, so I'd like a motion to that, to move that forward. Second? Okay, is there any discussion or questions from the members of the board? Is there any public comment on the motion? All those in favor of the motion as it's stated, please say aye.
Aye.
Any opposed? So done.
We thank you.
You're very welcome. Thank you for being here. Thank you. Thank you.
Oh, I didn't say this.
Okay, so we're going to we're going to move to item number 12 and hear from Mr. Frank. So Mr. Frank, would you come forward, please? And Ms. Cordray will be here in a moment, so she'll join you at the table when she is here.
I have some prepared remarks. They will take less than 10 minutes.
Thank you.
Is that okay?
So why don't you go ahead right now?
Okay. Last July, your board authorized the executive director to undertake an evaluation of the medical board's programs. During September, my firm was awarded a contract to perform this assessment. We began our analysis during November, and earlier this month provided medical board management with a draft final report. The purpose of our study was to review the medical board's organizational and management structures and core programs to identify strengths and weaknesses of current operations and develop recommendations for improvements. The scope of the project also encompassed a review and analysis of the sufficiency of fees and the value of services provided by external agencies and contractors, and also identification of functions that could possibly be eliminated to enable redirection of resources to more critical functions. To assess the medical board's governance structure, we prepared and disseminated a survey to obtain your input regarding the structure and composition of the medical board's governing board, board capabilities and effectiveness, and the effectiveness of training provided to board members. However, as of late June, a sufficient number of completed surveys had not been returned to enable development of any findings, conclusions, or recommendations for improvement in these areas. With respect to the sufficiency of the medical board's license fees and fund reserves, results of our review show that within 2 to 3 years, the medical board's reserves are likely to decrease to a level equivalent to less than 4 months' operating expenditures. Consequently, an adjustment to fees is not supported. The scope of our assessment encompassed a limited review of the licensing program. Earlier this year, Hubbard Systems Consulting completed a detailed review of the licensing program, focusing on the processing of license applications. We completed a critical review of Hubbard's report and also incorporated results of other related analyses that we performed. In addition to recommending various improvements in licensing-related business processes and technology support systems, Hubbard recommended increasing the number of authorized permanent licensing section positions from 26 to 41 positions, an increase of 15 positions. If Hubbard's recommended staffing increases were fully implemented, total authorized staffing for the licensing program would increase by 33%. With approval of the Department of Consumer Affairs, earlier this year the Medical Board established and began filling 8 new licensing program positions. These additional positions fully restore positions lost earlier in the decade and would actually exceed the total number of positions authorized for the licensing division at any point during the past decade by 10 to 20%. However, during this period, licensing division workload grew modestly. For example, since the middle of the decade, the number of license applications received has increased by about 10%. Results of our analysis support the need for the additional 8 positions that the Medical Board has been filling. However, Hubbard's related recommendation that the Medical Board seek authorization for an additional 7 positions for the licensing program is not supported. Also, Hubbard's recommendation to upgrade 2 of the licensing section's remaining 3 office technician positions and to completely eliminate the use of student assistants and retired annuitants or of student assistants would shift clerical and administrative support workload to higher level staff. finally, without Hubbard's recommendation to establish to increase the number of licensing program management positions, their recommendation to establish a new assistant division chief position would not be supported. In summary, the results of our analysis do not support additional increases or upgrades in licensing program staffing at this time. Enforcement program. The principal focus of our analysis efforts has been on the medical board's enforcement program. Initially, we completed a preliminary diagnostic review of the medical board's expenditures and enforcement program and performance during the past 5 years. The results of this review indicated that subsequent to implementation of vertical enforcement during 2006, costs for legal services provided by the Attorney General have escalated rapidly, while other legal service costs declined. Concurrently, the number of cases referred for investigation, the number of completed investigations referred for prosecution, the number of accusations filed, the number of stipulated settlements and proposed decisions submitted, and the number of disciplinary actions all declined. Additionally, the average elapsed time to complete investigations increased, while the average elapsed time to complete prosecutions decreased. Given the amount of funding utilized for legal services provided by the Attorney General, currently more than $1 million a month, and these performance trends, it was jointly determined that the primary focus of our assessment should be on 1, identifying and assessing the impacts of vertical enforcement on the enforcement program, 2, identifying and assessing the benefits provided from the increased expenditures for vertical enforcement-related legal services, 3, identifying and assessing other factors contributing to deteriorating enforcement program performance, and 4, developing an enforcement program improvement plan. To support our assessment, we interviewed Central Complaint Unit staff at 6 of the medical board's district offices, and representatives of the Attorney General's offices in Sacramento, San Francisco, Los Angeles, and San Diego. Medical board staff produced several dozen sets of statistical data pertaining to intake, screening, investigation, and prosecution of complaints, disciplinary outcomes, and numerous other related activities and events. We filtered, compiled, summarized, analyzed the data provided. Where needed, replacement or supplemental sets of data were requested and provided. Some statistical data was provided to us by the Attorney General's Health Quality Enforcement section, including data regarding attorney time charges for investigation and prosecution-related services. Where appropriate, we incorporated the Attorney General's data into our analysis, but much of the data provided by the Attorney General was only recently provided and was of limited utility, and with some isolated exceptions was not used. Overall, results of our assessment show that the vertical enforcement has been implemented very differently in different geographic regions of the state, with significantly different impacts in terms of cost effectiveness, service levels, and outcomes achieved. These differences provide an opportunity to identify best practices, reverse the deterioration in performance that has already occurred, and enhance consumer protection by instituting a more uniform and more effective statewide approach to investigating and prosecuting complaints. Identification, analysis, and documentation of the different ways that vertical enforcement has been implemented in the different regions of the state, and identification, analysis, and documentation of the different fiscal and performance impacts that these different approaches have had has been a very difficult and complex undertaking. We are currently reviewing results of all our analysis with medical board management and refining our suggested recommendations for improvement. Within the next week or so, we plan to submit the draft report to the Medical Board's Report Review Committee. A period of several weeks is expected to be needed by the committee to complete their review. The timeline for incorporating any further modifications or refinements to the report and submitting the report in final form will be determined in consultation with the Report Review Committee and Medical Board Management. It is anticipated now that the final report will be presented to the board at its November meeting. Thank you.
Mr. Frank, could I missed it in the beginning. I know
Okay.
you probably addressed it, and I thank you for your remarks. And I would hope that a copy of your remarks would find themselves going to Ms. Whitney directly. A copy of those, please. Did you address the issue of, you addressed, but could you repeat it, the issue of the number of board members on this board vis-a-vis the need to do the job that it needs to do?
Have not addressed it. We look back through the history. I can say that the number of physician members on the board is the lowest it's ever been in 20 years at least of history of the board, but our assessment was going to be dependent on getting sufficient number of completed surveys from the board members to get your input regarding that and the other topics, and we, as of the end of June, had not received a sufficient number of completed surveys to be able to complete that analysis.
Shouldn't that have told you that maybe we don't have enough board members? Thank you, Mr. Frank. But before I move on, wait.
No, yeah, I don't know if it's appropriate to ask questions or it's premature.
Sure.
Well, I'm on licensing, and you went over that just a tad quickly. And I don't have all the statistics at my fingertips, but it was my impression that the increased number of applicants was more than 10%. Now, I'm not quite sure, but the other factor is that I'm really confident that I've been told that there's an increased proportion of international applicants. And we've been told that that takes longer to process. So did you factor in, or do you not feel that increased processing time is in fact valid?
Yeah, again, I did not do a detailed analysis of the licensing program, the workload, the workflows, and so on. My observation was this, that the staffing levels, the authorized staffing levels with the additional positions are about 10 to 20% greater than they've ever been over the past decade.
Yeah.
And during that period, the license application numbers in total have gone up about 10% since around the middle of the decade.
Yeah,
which is less than the increase in the total authorized staffing, which is more like 10 to 20%. So it's not a perfect, it's not a detailed engineered time standards analysis, which we do recommend, we are planning to recommend conduct of a more detailed workload and staffing analysis for the program for various reasons besides what you're saying. But overall, it seems like the staffing levels and the workload are not out of alignment currently, and the major issue we were trying to address was, does it appear that there's a need for the 7 additional positions? And it doesn't appear from the aggregate data that there is.
Well, I guess since we are so sensitive to being fiscally responsible, and I, again, may be wrong in my statistics, but I thought I was recalling that the recent proportion of applicants was 40% international, and that the time required to process one international was significantly higher. I think factoring in that increased case complexity is very valid before drawing, at least in my opinion, specific conclusions. And if we could just kind of make that preliminary, because we are sensitive to being fiscally responsible, and it seems that that factor is not insignificant. Okay. Also, regarding the complexity of the cases, the upgrade of the job description to say that the higher level complexity doesn't warrant higher grade employee also seems at this point preliminary, in my opinion.
Thank you. Dr. Sorensen, are there any other questions from any of the members of the board? Are there any statements from any of the members of the public? So, thank you very much. Ms. Cordray, please don't go anywhere. You disappear too fast. Thank you, Mr. Frank. I would like to acknowledge the retirement a month ago from state service of a member of our executive team, Janie Cordray. Janie served most recently as the board's research specialist. She began her career with the state, with the Franchise Tax Board in 1974, and she worked her way up the ranks and joined the medical board in 1991. She worked in several positions from information officer to licensing manager and finally research specialist. Staff and members of the board came to rely on Janie as the go-to person on arcane issues no one else knew much about, from obscure scope of practice issues to equally obscure reporting requirements. One of her last assignments was to staff the Advisory Committee on Physician Responsibility in the supervision of affiliated healthcare professionals, probably the longest named committee in the board history, but Janie was up for the challenge and the perfect choice. For over a decade, she has worked on making cosmetic procedures safer for consumers, for helping develop legislation, to writing articles, to educating physicians and other healthcare providers and the public. Janie, I have for you a retirement gift from the state of California. Thank you. On behalf...
I just got my first retirement check. I thought that was it.
That was it? Oh, well, then you come back to work, okay? And we also have a resolution for you, but this is for you. Would come forward, please. And so now we have a resolution for you. And as to not read a resolution, because there's nothing more boring than what they write about you, it's not your funeral, okay? But let me read you the last paragraph. Don't. Resolve that we, the members of the board, do hereby extend to Janie Cordray, a.k.a. Smarty Pants, know-it-all. I didn't write this either. Our sincere and grateful appreciation for her dedicated service to the Medical Board of California and to the state of California. Our congratulations on her well-earned retirement and our best wishes to her for continued success, happiness, and good health in the years to come. And it's framed.
Thank you very much. Really, thank you, Jane.
So now we're going to move on to agenda item number 24, the Enforcement Chief Report. Ms. Threadgill, would you please come forward?
Good afternoon. I promised Dr. Gitnick that I would not delay his departure at this last meeting, so I'm almost on schedule. I'm going to try to keep it moving.
30 seconds.
Please refer to agenda item 24A. May I have a motion to approve 12 orders to restore licenses following completion of probation and 5 orders for surrender of license during probation or an administrative action.
Second.
Any comments from the board? I don't have any public comment, right? All those in favor of this motion?
Aye.
Any opposed? Any abstentions? So done.
Moving to agenda item 24B on page 183. This reflects the use of experts by specialty during the past quarter. Please note that the number of experts in our database has increased from 1,106, to 1,161. I will be coming back to comment further about our expert reviewer program under my report on the CPEI positions. Vacancy status. Okay. The enforcement program has an overall vacancy rate of approximately 9% or 5% when you delete the vacant positions that have candidates identified and moving through the selection process. We have been doing everything we can in order to recruit and maintain investigators because it takes so much time to have them trained and fully available to investigate cases so that we can do our job efficiently. And since we know we can't compete with other agencies salary-wise, we started brainstorming and we undertook a project to identify the characteristics of our most veteran successful investigators that really like what they're doing, want to stay, aren't concerned about the money as much. And we identified a number of common characteristics, and we've developed questions for the interview process in order to elicit information about candidates that comport with these characteristics that we identified, and this has been extremely helpful. Staff has done an outstanding job of identifying candidates, and prior to hiring, we're happy that we're getting a group that appear to be wanting the job and are willing to stay the long term. So our patience in this regard has paid off. I'm going to mention a little bit about several of the units in the enforcement program that are little seen. First, the Central Complaint Unit staff stepped up tremendously this past quarter. Although the unit was short-staffed due to maternity leave and the unfortunate demise of an employee, they covered their unit with no loss in productivity. I wish to make honorable mention of phenomenal efforts from Ramona Carrasco, Charlene Smith, Fred Holbrook, Mike Jenny, Keith DeGeorge, and Christina Hayden. Are you here? Could you stand up? The Discipline Coordination Unit also did an outstanding job during this past quarter. They processed over 95 pleadings and 91 decision and orders, which is no little feat, many of them requiring a lot of interaction with the attorneys that were drafting some of these documents. Our OSM unit is now located in the San Dimas office location, and the former Diamond Bar office has relocated there too. OSM recently seized in very timely over $100,000 of contraband contact lenses and arrested 9 unlicensed individuals who were illegally selling them. All of these cases have been filed with the city attorney or the district attorney. And this was very timely because of the rage of the Gaga Big Eyes, and I thought it was just really appropriate that they were reporting this back, since this is so dangerous to a dangerous fad for the young kids that are buying these illegal lenses and inserting them. The OST, which is our Operation Safe Standards of Training unit, has been working on a variety of projects that will benefit the district investigative staff. One project you're already aware of is training, planning and developing the training conference that is planned for October of this year. They also are working on a new evidence policy and database for tracking evidence, and that is almost complete. And they are in the process of completing background investigations in record time. The Age Case Counsel concept continues to be effective. Since implementing this concept, we have reduced overall case age average by 25 days. In conjunction with this, the deputy chief and I have been trying to give incentives to the district offices who reduce all of their cases that are over a year old for a consistent period of time by promising them to serve them in any way they wish. So they've been directing us to do things. We've had an opportunity now to serve one district office pizza, and we donned aprons and chef's caps and served them. And recently we had we even employed Linda Whitney, the executive director, to assist us in serving ice cream sundaes to Sacramento district office. Wow. So everybody is anxious to get their share of service from me, and Laura. So they're moving the cases right along. There was an overwhelming response to the recent advertisement for medical consultants that appeared in our newsletter, and I have no doubt that we will have an abundant number of well-qualified physicians for vacancies that we're seeking to fill. The probation unit has obtained a biological fluid testing contract, which will result in our being able to possibly reutilize an analyst for other purposes. The department also has obtained a biological fluid testing contract, random testing contract, which we will be using as well, and we're going to use both for flexibility. The Department of Consumer Affairs obtained 22.5 positions for us through the Consumer Protection Enforcement Initiative, and I'm going to ask Kim Kirkmeyer to come forward and provide you with an update on this initiative.
Good afternoon.
Welcome.
Thank you. I'm here just to talk briefly, as Renee asked me, on the Consumer Protection Enforcement Initiative. We did obtain about 140 positions overall, actually, for all the Healing Arts boards. So we were really excited when that budget change proposal went forward. At the last time I think I was meeting with you all, it was thought that it may come forward with half. So we were really excited when it went to conference and they approved it for the 140 positions. So we believe that we need to provide the boards, help the boards get the tools that they need, and staffing is one of them in order to reduce that time frame. So we're really excited about that budget change proposal. The other thing, we're just really asking the boards to go forward and begin recruitment processes for these positions. And I was actually speaking with Ms. Threadgill and Ms. Katie actually today, and they're moving forward in that. I'm going to say they because, you know. Anyway, it's hard habit to break. They're moving forward to fill those positions, so we're really excited and glad that you're moving forward in that step. The other thing for the Consumer Protection Enforcement Initiative we've begun is to obtain information and statistics on the performance measurements. These measurements are going to address cycle time, volume of complaints, cost, customer service, and probation monitoring. So these are actually going to be posted on your website in October. So that's going to be something that's out there for the public to see. The other thing that we're really, from my perspective, one of the things I'm the most excited about for the Consumer Protection Enforcement Initiative is the fact that the budget change proposal for the BREEZE project did get approved, and we are moving forward, and we couldn't have moved forward without the assistance of those that participated earlier in the CRIMS project, and we do thank you for providing your staff and the assistance from that. And we do want to offer you the opportunity. We have an individual from our office. She's our Chief Information Officer, Debbie Balaam, because I know there's a lot of questions regarding the BREEZE project, and she would be more than happy to come back and make a presentation regarding that project if you'd like that. And she's also here today if you have any questions regarding that project. The other thing that we're looking for CPEI is that obviously the Senate Bill 1111, which was the legislation to carry a lot of the proposals we were hoping to make changes for the enforcement processes, that was actually defeated. It didn't make it out of committee. However, what we're asking is the boards to move forward with regulations to implement any of those provisions that you can. Now, a lot of SB 1111 was based on the medical board, so there may be a lot of them. We actually identified 9 for some of the other boards, but I don't think that number is probably as that high for the medical board because, again, some of them were brought from the medical board statutes. So we would just encourage you to look at those with your legal counsel to identify regulations that you can move forward. And I think unless there's any other questions or anything else you wanted me to address, Renee.
Thank you very much.
Wait. You're going to be coming back, right? Okay, then I'll wait for you to come back.
If you will turn to agenda item 24D, I believe, at page 191 of your packet. It's the chart that shows how some of these positions are going to be deployed. It's not complete, however, it'll give you an idea of what we have planned in order to assist in reducing our timeline. These are non-sworn positions that will be used mostly on the front end in the process to, one, reduce the number of cases that need to be assigned and investigated by an sworn staff, thereby hopefully lowering the sworn staff caseload so that they can address the more serious issues in the field. This org chart is not complete in that it does not show probation, which would ordinarily be on here under Susan Katie, the staff services manager, as well.
We don't have that one. We have one that looks different.
They did. Okay, I'm sorry. How did that happen?
Just expert support.
Okay. Moving along, I'm going to ask that Carlos come forward and provide you with his report on VE.
Okay, so we're moving on to the agenda item number 25.
Good afternoon, Carlos Ramirez, Office of the Attorney General. During this last quarter, we have continued to work with your Chief of Enforcement in identifying and improving ways that we can expedite the obtaining of medical records and perhaps fine-tune some of the methods that are being used in other aspects of investigation. We hope that we'll be finished doing this during this quarter, and those will be implemented if possible. Again, just obviously, we want to help, we want to assist in expediting the investigations, but at the same time, we have to make sure that we safeguard the privacy interests of the patients. So I'd say it's a tough balancing act, and we have a little room to maneuver, but not much.
Okay, thank you. Any questions for Mr. Ramirez? No, thank you very much for your report. We're going to move on to okay, so we're going to...
Thank you very much.
Thank you. Ms. Kirchmeier, would you come forward, please? You're going to give us a report from the Department of Consumer Affairs, please.
First of all, I just wanted to say thank you again for having me here. Unfortunately, I have to send, Director Steger was actually hoping he would make it over here this afternoon. He has to send his regrets. It seems like always at the department, Friday afternoon seems to be the time that we always are inundated with requests. So he's actually back at the office working hard. So he sends his regrets and he wished that he could have been here this afternoon. I am here on his behalf to talk about some of the other projects beyond Consumer Protection Enforcement Initiative that the department is working on right now. One other thing that we are working on, one big item, is Senate Bill 1441 Uniform Standards and encouraging the boards to implement those standards. Senate Bill 1172 is still going through the process. That's the legislation that you need to implement some of those standards. There also could be regulations and policy implementation. So we're just encouraging the boards to look and go through those guidelines, and I know that you discussed them at the last meeting, and we're just encouraging to move forward with the regulatory process. And I know that your disciplinary guidelines that are going through right now, I think you're going to wait and finalize those from what I understand.
We're not moving forward with any additional regulatory changes regarding SB 1441 until we see what happens to SB 1172. Should that pass, then we will work to implement that.
Okay, great. And then the next thing I wanted to talk about was healthcare reform. The department will begin holding meetings to discuss the impact of this reform to the board's licensing and enforcement processes. As you heard earlier today, it's going to put anywhere, what we've heard, about 8 million individuals into the healthcare system. That's going to be a huge impact to both your licensing and your enforcement processes. We're requesting that the boards begin to put this topic as a standing item on their agendas, and I just want to thank you. This board is actually ahead on this issue, and you've already had the presentation, and thank you, Ms. Whitney, I assume, for bringing that individual today. And actually that was really good for us to hear as well, because we would probably want to get that individual going out to the other boards as well and speaking. So thank you for that bit of information today, and the presentation was a great presentation. And the next item that we're working on is the licensing reform. This is pretty much our most recent project from the department, and we are actually beginning this process. It's very important that we get individuals licensed in a timely manner in order to for them to join the workforce. And we've begun phase 1, and that's the gathering of statistics for what our current processes are. And by September 8th, we've been asked to begin reporting monthly to state and consumer Consumer Services Agency on each board's licensing. And that basically is the licensing from how many applications you have pending, how many applications were approved, how many were withdrawn or denied, and then a pending at the end of the month. And we've been working with Ms. Whitney and staff to get those reports going so we can have those beginning September 8th on an ongoing basis. The second phase of this project is actually going to mirror somewhat what we're doing for the CPEI, for Consumer Protection Enforcement Initiative. And that is we really want to look at licensing processes and establish performance measurements. And I'm going to say that with an added clause, because as we went through CPEI, a lot of the boards, including the Healing Arts boards specifically, they do processes very similar, and it was very easy to establish performance measurements that could fit everybody. When I look at the licensing processes as we've been going through this, licensing is almost different, not only just across all 38 boards, but also even between the licensing categories within some of the boards. So that's going to be a little bit different in setting performance measurements, because it's going to have to be done on an individual basis by board. And I think that Ms. Whitney would agree that it's not something you can fit across every board. So we are going to be helping establish those, but then the boards will have to be setting their own targets within those performance measurements. The other thing that we want to look at is the laws and regulations and determine if there needs to be any changes in any of the board's laws and regulations to help streamline the process. And then finally we want to look at, is there any best practices out there? Maybe the boards can learn from each other even though their processes may be different. And I believe that is all that we have, since I've already covered CPEI, unless you have any questions.
Do any of the members have any questions? I have some.
Okay.
Can you give us a status report on the CPS review of the department's resource center section?
The last, and I may have to get back to you on this. Yes, it's a contract. Just so you know, the department is undergoing a contract review of our human resources area and our personnel staff. That's been one area where the department we've had some problems with, and we just really wanted somebody to come in there and look at those processes and determine where efficiencies could be made. So that's the background on that process. I believe right now they're still gathering the evaluations. We did get, at first we didn't have a very good turnout from the boards as far as providing us responses, so we actually went out to the boards again and asked, could you provide more information to us? And those have come back. As to the deadline, I'll have to get back to you on that, because I'm not sure what the final date of that is, but I will get back to you on that.
Thank you. And just a question, like for example, with the CPI and the different kinds of processes that you are organizing under the department's aegis, that within the program of trying to organize this, that it doesn't just come with people and money. It has to have a place to sit. They have to have an office to work out of. They need to have supplies. They might need to have cars. So it's the whole entity. So we want to remember and remind you that we are.
It's more than just people.
Right. So with all the success you're having, we want more success.
Okay.
I want to thank you for your time and energy, and thank you for being here, and send our best to your boss.
I will. Thank you.
So we're going to move on the agenda to the final item. That's number before adjournment. That is agenda items for the next board meeting. Dr. Moran.
I'd like to address the void that's been created by our terminating the diversion program, and that currently we don't have a way to ensure rehabilitation of physicians, and simultaneously protection of the public. I know that it's been complicated trying to find, the whole issue of contracting various centers has been complicated. So I'd like to take a look at that at the next.
So would you want to look at the void, or you want to have an update as to what has been going on?
Yes.
Okay, so total
whole thing.
Okay.
Yeah.
So what we'll do is go through the agenda from today and take a look at comments that have been made and suggestions that have been made to follow through and bring forward more and additional opportunities for discussions as well. And if board members have any suggestions in the next few weeks, please feel free to let our executive director know. Before I adjourn the meeting or ask for motion to adjourn, I just want to remind the board members that it's been a very stressful year so far. The staff has really come up to the plate. There's been new vision and new energy and new insight, and I want to take this moment really, I mean, I've done it and I do it as often as possible, but I really do mean it, to thank the staff, the entire staff, for the effort and the energy that they're investing in their jobs to ensure that we look good and that the people of California are in a better place than they were before. So I want to thank you again. So now I will entertain a motion for adjournment.
So moved.
Second.
Done. Dr. Gitnick. Good luck to you. The airport, I just wanted you to know the time. Yeah, you know what? We can't do things like this.